Good morning, everybody, and welcome to this mock exam, the second day of the session 2 of this academic year. And we have 5 cases which are being going to be discussed today. Again, all short cases, which are very commonly asked in the exam. They are the stones, strictures, pediatric cases, all a spectrum of them, which are being discussed by the expert faculty, and I would request all the residents to make use of this session. Now I would request, is Dr. Rajiv Sood there, Arun?
I have not seen him, sir. Not, sir, not to be seen him.
Okay, then I would hand over to Dr. Arun Chawla to conduct the proceedings.
Yes.
Over to you, Dr. Arun.
Yeah, thank you, Dr. Keshav, and warm welcome to faculty for today's session 2 exams, and welcome to all the residents. I think you are familiar with yesterday's exam. The pattern remains the same. We have expert faculty for today's exams. Dr. D. Ramesh from Bangalore, Dr. Prakash from Stanley, Dr. Mankmon from Lucknow, Dr. Venkatesh Krishnamurthy from NU Trust Hospital, Bangalore, Dr. Balgopal from Kochi. And you will appreciate, like yesterday, all the faculty have worked equally hard like you for not only acting as examiner, but acting as a teacher. So this will be both as examination and a teaching exercise. I request all the students to remain active. Put only the question in the chat box, not your comments on the answer which the examiner is posing to the students. This will help the faculty in the end of once his case discussion is over, he can just go to the chat section and reply to your question. But if your comments are there, it will be very difficult to discriminate what is the question posed or what is the comment given. And other thing is, at the end, we'll request you to put your feedback. That is very important part or very important exercise to make ourselves improving with every mock exams. And with this, I welcome you again, and I hand over and invite Dr. D. Ramesh for the first case, and the residents for today's case, Kiran.
Good morning, sir. Today's case, we have Dr. Nikhil and Dr. Sagar.
Nikhil and Sagar, please keep your video and audio on. Over to you, sir. Dr. Ramesh.
Yeah, thanks, Dr. Arun and Dr. Keshav. I'd like to thank USI and the office bearers for inviting all of us over. Is Dr. Nikhil and Dr. Sagar logged on?
Yes, sir. Yes, sir. Good morning, sir.
Wonderful. Good morning. I will share my screen with you, and then we will start the presentation. So this is going to be a short case, so it will run for about half an hour. This will normally in the exam, it will either be kept as a case for you to examine quickly and present, or it will be something like a ward round where your colleagues will present and then you'll have to ask leading questions and take the discussion on further management. Are the slides seen?
Yes, sir, they are seen.
Okay, so today we'll talk to you about a story of a 54-year-old male laborer who presented to the hospital with bilateral flank pain of 3 months. This flank pain was colicky, intermittent, mild to moderate intensity, and radiating to the back. He also had increased frequency of micturition more than 10 times a day and in the day, and 2 to 3 times at night. So a 54-year-old male comes with this history. Dr. Nikhil, what would be your thoughts?
Sir, so there is increased amount of frequency during day and night time, sir. It is LUTS, sir, or urinary tract symptoms the patient is having, and also bilateral flank pain is present.
Yes. So what would
lower
be
tract, there could be a stone disease, sir, or it could be.
Or it could be?
Yes.
Stone disease. You have to be more specific. He's got
sir.
bilateral flank pain. So somebody who presents with bilateral flank pain has got bilateral pathology.
Yes, sir. Or the lower tract
what do you think?
also can cause bilateral flank.
Okay. The predominant symptom seems to be back pain causing colicky.
So some bladder.
Dr. Sagar, you want to take it?
If the urine is obstructed, sir, that also stricture or stone or these things.
You have to be more specific. Which would cause bilateral flank pain?
Sir, bladder stone can cause, sir.
Why would bladder stone produce bilateral flank pain?
Sir, large stone causing obstruction and patient is having
You never
urinary
get you never get upper tract obstruction in bladder stone. Why can't you be more straightforward, simple? Don't look at
Fixed.
complex situation.
Yes.
Which is the most common cause of flank pain in your
Also.
outpatient clinic? No, your audio, the audio signals are bad.
Some bladder pathology which is called or a bladder.
Why are both of you considering bladder pathology? Why won't you consider first upper tract pathology?
Bladder outlet obstruction causing reflux to bilateral.
Wow. So, see, how often have you seen in a 54-year-old male reflux causing pain? Which is the commonest cause of loin pain in a 54-year-old male? The first cause, when you sit in outpatient, what would be your first thought? Stone disease.
Stone disease, sir. Renal
Yeah,
stones,
so
sir.
patient can have stones
Yes,
on both sides.
Yes, sir. You can have
Yeah, so you can have
bilateral
bilateral stone. That would be the commonest differential diagnosis, isn't it?
Yes, sir. Yes, sir.
So, in view of his associated lower tract symptoms with bilateral flank pain, can you give me any other differential diagnosis?
A bladder outlet obstruction can with bilateral reflex. That can be one possibility. It can be a renal stone disease along with bladder outlet obstruction in chronic.
Okay.
Or it can
Anything
be a
else?
multiple stones, bilateral ureteric calculi along with bladder calculi also. Sir.
Can you think of an
disease?
inflammatory pathology causing obstruction and lower tract symptoms? Quite common in our country.
A genitourinary tuberculosis can be one.
Yes.
Yeah. Can the GUTB have the same symptoms?
Yes, sir. They can have, sir. Frequency is present.
So now we have discussed 4-5 probabilities. Among this, could you sequence them? Which is more common?
Sir, G.
Most common will be bladder outlet obstruction with the bilateral reflex. Second thing
How
will be
often? Now
genitourinary.
Sagar, you're in your final year. In the last 3 years, how often have you seen a patient with bladder outlet obstruction, vesico-ureteric reflux producing pain? Have you seen any case?
Yes, sir. I have seen cases, but not so frequently.
What is the commonest cause of bilateral flank pain in your practice?
Stone disease.
Yeah, so I think all of you should put stone disease as the first differential diagnosis in such a case scenario. Why would a stone disease produce lower tract symptoms? Why would a stone disease?
Probably a distal ureteric calculus, which is
he could be having a low ureteric calculus. Any other reason why he could have the symptoms? Can he have associated urinary infection?
Yes, sir.
So he can have associated urinary infection.
Yes.
So the commonest cause of these kind of symptomatology will be bilateral stone disease. It could be an inflammatory condition producing obstruction. That is commonest again is genitourinary tuberculosis. In a 54-year-old male, what are the other causes of bilateral flank pain?
Sir, could be GUTB also, sir.
We finished GUTB. Don't be repetitive.
Yes.
You finished stone disease. You finished GUTB.
Sir,
bilateral pathology.
Bilateral PUGO also, sir.
Yeah, congenital anomaly in a 54-year-old male, bilateral, very unusual. It will not come high up.
Yes.
Cystic disease of the kidney.
Yes, sir. Cystic disease.
That
also.
could be one of the differential diagnoses. So I don't think you should consider low urinary tract obstruction with reflux as a differential diagnosis at this point in time. Okay, you never entertain a clinical diagnosis of vesico-ureteric reflux causing bilateral flank pain in a 54-year-old male. It will not be accepted in the exam. You'll have to tell common things first.
Okay.
Right.
Yes.
So we'll move forward. This patient did not have any history of fever, vomiting, hematuria, dysuria, pyuria, lithuria. He had no comorbidities. He was a smoker and no history of alcohol consumption. Are these symptoms give any relevance in eliminating any of a diagnosis?
Yes, sir. Lithuria is not there. So lithuria, hematuria, pyuria, these things will eliminate the infective conditions, sir. And also the stone disease also has been eliminated.
No, you can't eliminate stone disease. Not all patients with stone disease have previous history of lithuria. Just because he doesn't have history of lithuria, that does not eliminate a stone disease. You can fairly be certain that he's unlikely to have an inflammatory condition. Dysuria is one of the predominant symptoms in tuberculosis. He does not have dysuria, but he does have frequency. He's got no history of fever. So inflammatory condition is less likely. So we are likely to be dealing with an obstructive condition. Commonest again will be a stone disease, right? Bilateral PUJ, I would not entertain diagnosis primarily in a patient who is 54 years old. It's somebody younger, yes, but not somebody at 54. Does smoking have any relevance in this patient? Somebody has mentioned history of smoking for 20 years.
Yes, sir.
Yes.
How would this be
Smoking,
relevant?
See, these things are bladder pathologies and also
cause
appetite.
for
Yeah, this history of smoking will have relevance if one of the diagnoses that you entertain is going to be malignancy, either a transitional cell carcinoma or a renal cell carcinoma. You could have some correlation with the history of smoking. That we'll know only when we do an evaluation by clinical examination and by the investigations whether we are dealing with a malignancy. But with this history, malignancy is unlikely to be a cause of these symptoms. Bilateral flank pain with lower tract symptoms, you will not entertain a diagnosis of malignancy upfront here. Investigation might prove otherwise, but in your clinical discussion in a short case, malignancy will be very, very low down in your differential diagnosis. The other differential diagnosis one would need to consider is a potential for a neurogenic bladder. He's got, if you see the history, he's got radiating back pain with low urinary tract symptoms. So one of the differentials could be a neurogenic bladder, especially in view of lower tract symptoms. Okay. So we would entertain a differential diagnosis of bilateral stone disease, genitourinary tuberculosis, probably a neurogenic bladder. And then we'll see how we evolve in examination and in investigations. Is there any doubt with you so far?
No, sir.
Yeah, so both Sagar and Nikhil, I will advise you not to bring in a diagnosis of lower urinary tract obstruction with vesico-ureteric reflux in an adult male. Right? Yes. It's not a clinical diagnosis.
Okay.
So let's move forward. What we see on examination. His examination is fairly unremarkable. What would be relevant is he's got no pallor. He's got no pedal edema. So does this have any suggestion to you, Dr. Nikhil? What does that tell you? That he's got no pallor, no pedal edema? See, any patient who's got bilateral flank pain, you know he's got bilateral pathology. So immediately your brain should start thinking that he's got potential underlying renal disease. So he could be having renal failure. So your general examination would throw some clues whether he's got renal failure. If he doesn't have anemia, that means you know that it's not a long-standing disease and he doesn't have renal failure. He's got no pedal edema. So that also gives an indication that he may not be having renal failure, may not be having. Okay. So negative features, even on general examination, will throw a light on what is the underlying pathology. So it's important to have a good general examination to find out what is diseases, underlying diseases, or the consequence of the disease. Are you okay with me so far?
Yes,
yes,
sir.
sir. Yes.
Yeah. So moving on to systemic examination, there is nothing specific. Abdomen is normal, external genitalia is normal, prostate is grade 1, no nodules, testes are normal, all the other systemic examination is normal. So this completes the examination. So at the end of the history and a clinical examination, Dr. Sagar, where are we into the clinical diagnosis? So this patient is with you in the clinic. What would be your clinical diagnosis now?
I would like to continue with the same differentials as a bilateral stone disease or probably infective etiology like genitourinary tuberculosis. And also I'd like to keep neurogenic bladder as one of the differentials.
Neurogenic, you would have probably got some clue in the focused neurological examination. You would always, when you have a clinical suspicion of a neurogenic bladder, you would always in your systemic examination include a focused neurological examination. You will check his gait. You will do a perianal sensation. You will do a sphincter tone. So this will all be part of your focused neurological examination. Okay. So when in your history, you have mentioned that neuropathic bladder as one of the differentials, in your clinical examination, never fail to mention a focused neurological examination. If you miss it, then your examiner knows that you're not thinking in the right direction. So never miss a focused neurological examination in a patient who has got low urinary tract symptoms. Okay? And this would include a perianal sensation, a sphincter tone, and a bulbocavernous reflux. So you are expected to know what is the afferent and the efferent innervation of the focused neurological examination. Are you both familiar with this?
Yes, sir.
Yeah, they will ask you about the afferent and efferent pathways of the focused neurological examination. So we'll not go into the nitty-gritty of those, but it's mandatory that you should do a focused neurological examination in such a clinical scenario. So now that our differential diagnosis has not changed, how would you like to proceed with this patient who is sitting in your clinic?
So I would like to do some clinical investigations in the form of urine routine microscopy, a TBC, a renal function test, and ultrasonography of the abdomen.
Yeah. So yeah, while you're basically right in the way you approach it, there are two ways of handling this. Different examiners would want it differently. Some of them would want you to do an ultrasound first because ultrasound is a part of your clinical examination today, and almost all clinical outpatient departments have an ultrasound. So you will not be wrong if you say you will do ultrasound first as a part of your extension of your clinical examination, and then based on the ultrasound findings, you can take the rest of the investigation forward. On the other hand, you have one set of examiners who are basic exam. They're very, very interested in knowing your basic knowledge. So they will start from a urine examination. So as a urologist, you should know everything about the basic investigations, especially in a patient whom you're suspecting to have either a stone disease or inflammatory conditions involving the upper tracts. So both ways you're right. So you could choose either to do an ultrasound first and then proceed with the routine investigations, or do your routine investigations first and then proceed with ultrasound. So Dr. Nikhil, we'll put you up the investigations. So tell us what you find in this and how would you proceed from here?
So in this thing, the characteristic feature is that the patient's creatinine is elevated, so 2.20 is his creat, and rest of all look normal, sir. HbTLC, electrolytes, and serum calcium and urine culture, there is no growth.
Yeah. So you have a patient who has got bilateral symptoms and he's got an elevated serum creatinine. His counts are okay. Doesn't seem to be having too much of infection. His urine culture is negative.
Yes,
so
sir.
does this contribute? Does this investigation contribute to the diagnosis?
So his creat is elevated. Could be some.
Yeah, but
some
creat
suspicion
elevation doesn't give you a diagnosis other than the fact that he has got renal impairment.
Yes, sir. At this point of time, like obstructive uropathy is one thing that I can think, sir, relating to his elevated creatinine.
Yeah. So what would you want to do at this stage?
Sir, I would like to get an ultrasound, sir.
You would like to get an ultrasound. In this investigation, the urine routine examination is not there. But if
Yes,
it's
sir.
a long case, people will go into details about urine routine examination in a patient like this. So we'll not venture into that now. We presume you know what the findings would be in a urine routine examination. So you next want is an ultrasound, is it?
Yes, sir. Ultrasound KUBs.
Sure. This is the ultrasound. The films are not there.
Yes, sir. Bilateral enlarged.
Bilateral enlarged kidney with moderate hydronecrosis, bilateral hyperechoic lesion in the kidney, post-acoustic shadowing measuring nearly 10 centimeters, occupying the whole kidney. Parenchymal thickness 7 mm on right side and 6 mm on the left side.
Yep.
So that gives a diagnosis of bilateral Stagon calculus with parenchymal thickness reduced on both sides.
Yeah. So now the basic question that one would ask is, in the patient who has got loin pain who comes to the emergency room with acute pain, which would be your first imaging of choice?
Sir, we normally do here CT, non-contrast CT KUBs.
You straight away, all patients who come with loin pain, do you do a non-contrast CT, or still
No,
would you
sir,
consider ultrasound as the first?
Yes, sir. Initial screening we do with ultrasound, sir, but then to get a definitive testing, we do a CT KUBs.
Okay, that's fine. All right. So this patient has got bilateral large stones and he's got a creatinine of 2.2. Dr. Sagar, how would you want to go forward?
I would like to go forward with a non-contact CT scan of the kidney ureter and bladder.
Okay. Why do you choose non-contrast CT? What are
Because
the advantages of non-contrast CT?
I would come to know about the calculus more detail, like HU of the calculus, the shape of the calculus, the parenchyma, pelvic LSI system. Along with that, um, perirenal any collections or any infections or is there or not any and what is the relation of the bowel with the kidney as I will be contemplating surgery for this patient, so that will be one of the important things I would like to discuss.
Yeah, you're perfectly right. So to summarize what Dr. Sagar said is non-contrast CT is the imaging of one-stop imaging of choice in patient with stone disease. It not only tells you information about the stone, it also tells you information the kidney and the surrounding tissue, and it also gives you the morphology of the pelvic calcium system. If the creatinine is normal, you could inject contrast and do a contrast and then CT urogram. It will give you a complete picture on your therapeutics also for this patient. So CT currently would be the choice of investigations in imaging any patient with stone disease. A few years ago, IVU used to be the choice, but now with the advent of CT, CT would be the choice. Have you any idea how much is the radiation exposure in CT scan?
So 500, sir. CT abdomen and pelvis, it is 500 distance, sir. Compared to an X-ray, it is 500 times.
Fine, I know. In terms of radiation dose,
So 10.
today's radiation dose is calculated in millisieverts.
Yes, sir. 10 millisieverts.
10 millisieverts is the radiation per this one. And what is the annual requirement in safety, radiation safety, maximum
Less than 50,
permissible
sir.
radiation exposure?
Less than
Less than
50.
50.
50. Good. Very good. So how do you want to proceed further? This is his X-ray KUB that was done. Somebody, Dr. Nikhil, you want to take this?
Yes, sir. Sir, it's this X-ray KUB, sir, showing bilateral opacification, sir. It's a bilateral complete slag on calculus, sir. Looks like that to me.
Yeah, one clue for all of you, when you read an X-ray in the exam, there are still examiners who want you to read it in the appropriate way, right?
Yes.
You should start with the axial skeleton. You should start with the bone, how the bone does. Is the appearance of the bone important for you in evaluating a KUB?
Yes, sir. Actually, the radio density we can know with the bone comparison to the stone, sir, like how hard the stone is on the X-ray.
No,
But
no.
still,
What about
CT
the
can give
appearance
us
of the
the
bone per
hospital.
se? What about the appearance of the bone per se? It's important to know about the bone.
Yes.
Yeah, so you should read a KUB in a systematic
That is
manner,
what.
right? Don't straight away jump to
Okay.
read the stone. You should explain how the spine looks, how the bony architecture is, whether
Okay.
there's kyphosis, scoliosis, and then whether the psoas margin are seen, then start with the opacities in the kidney. So this apparently is a bilateral stag on calculus, very radio dense. And Dr. Sagar wanted the CT. Dr. Sagar, there are some cuts of the CT available. Try to make an impression of what you see and tell us. Yes.
Yes, sir.
He does.
Both sides.
Yeah.
Both side of pelvic calcium system is full of calculus, sir. Parenchyma is almost equal. Thickness is equal on both sides. However, it looks like the stone burden is more on the right side as compared to the left side. Patient is symptomatic for both sides, so that we can consider.
Yeah. You also, besides mentioning about the stone, you should also look at other things. You want to tell anything about the parenchyma that you see? Is there hydronephrosis?
Yes.
All the pelvic system is occupied. There is no hydronephrosis as such, but parenchyma, there are some cysts in the parenchyma on left side.
Yeah, there is reasonably good parenchyma on the right side, though the left side it's not well made out. But the whole kidney is on both sides is occupied. The pelvic system on both sides is occupied by the stone. So how would you define a stagon calculus, Dr. Nikhil?
So stagon calculus is a large calculus sir, which is formed in the pelvis, and it can be complete or it can be incomplete. So complete is occupying all the calyces, sir, upper, middle, and lower calyces, and
You
occupying
don't
the
use the
pelvis
word
completely.
complete, you incomplete, you say partial.
Partial. Okay.
It's a partial or a complete stagon. Right.
Okay, sir.
Okay. So what do you want to do for this patient? Can you
Sir,
make
what,
out the type of stone? Generally in a stagon, what would be the composition of the stone?
sir, magnesium, ammonium, and phosphate.
Is it always magnesium, ammonium phosphate stones, or you can get different kinds of stones also causing stagon? For example, can you get uric acid stone as a stagon calculus?
Usually it occurs in combination, sir. Just one type of material not necessarily be present in stagon.
Yeah, stagon, though most of the time it's an infective stone comprising of magnesium, ammonium phosphate, but you can get stones of other etiologies also. You can get calcium oxalate stones, you can get uric acid stones also coming as stagon calculi. So you don't have to be fixed that it's always an infection stone. You can get metabolic stones. Cystine stones also going to form stagon calculi. So metabolic abnormalities also can result in stagon calculi. Okay? Right. So how will you go about managing this patient? We just have 4 minutes, so let's run through this quickly.
So this patient needs bilateral
Yes,
PCNL, sir. It's a large calculus.
Do you think he needs any further imaging? He's got creatinine of 2.2.
Sir,
We can.
I'll ask a direct
proceed with
question. Do you think he needs a nuclear scan of his
functional
kidneys?
study. So parenchyma here looks fairly good enough, sir. Looking at the CT scan, but
Would a
for
functional study, would
yes,
a
sir,
functional
functional
study
study.
add any information to you?
Yes, sir. It can add information that post-operatively also to counsel the patient. It will be.
Yeah, in this scenario with this creatinine of 2.2, it doesn't really add, especially in bilateral pathology. You're trying to salvage both the kidneys, so it's not going to add any further information other than getting a GFR, etc. It really doesn't add up too much in terms of investigations. So I think you could go ahead and start planning management of this patient. Which side will you operate?
Yes.
What would you do?
I would like to.
What would be
Right
the
side, I would
choice
like
of
to
treatment?
go for a multipuncture. PCNL will be the one.
Okay. So you would counsel the patient for multipuncture. If possible, you will do it with minimal number of punctures, because the morbidity of any surgical procedure, especially PCNL, is directly related to the number of punctures and the tract size. So you would like to remove the stones with minimal number of punctures as possible, but you would counsel the patient that it might not be possible to remove it with a single puncture. He's got a creatinine of 2.2. In a patient with a creatinine of 2.2, would you like to divert his urine, optimize him, and then do the procedure?
I don't think that is going to work because of both sides LSL system is already involved, and unless we clear the stone, rare chances it will improve on it. But I would like to consider hydration and antibiotic therapy before starting proceeding with surgery.
All right. So what you need to do in any patient with stagon calculus is you should get cultures done, see that is infection free. You may not be able to get his infection out. At least you should start antibiotic before you start intervention. That's number one. Second is it's always good to have a nephrologist consult up front in a patient who has got an elevated serum creatinine, because post-operatively his creatinine could deteriorate. So it's always good to have the nephrologist involved in the management of this patient up front. If his creatinine is significantly high and he's got electrolyte disturbance, it might be a good idea to have him on dialysis, optimize him, and then take him up for surgery. The other issue is that these patients who got raised renal parameters have also got coagulative abnormalities. You should check his coagulation profile and then optimize him before you consider him for surgery. If required, you should cross-match a couple of units of blood and then have him ready before you go into the operating room. Okay? Because the bleeding complications is definitely higher in a patient who has got renal failure. And the stone volume has a direct correlation along with the number of punctures and the tract size in terms of bleeding.
Yes.
What is the average transfusion rate in a patient following PCNL?
Around
Suppose you do 100
5%.
PCNLs, what would be the average number?
Around 5%. However, it directly
Between
depends
4
on
to
the
7%. There's an
size.
excellent paper from Nadiad in the Journal of Endourology. The approximate percentage of transfusion is between 4 to 7, and there's a direct correlation between the number of punctures and the tract size in terms of post-operative transfusion and bleeding. Right. So you take this stone by PCNL, counseling the patient that you would require more than one puncture to clear the stone, and you may not be able to completely clear the stone. So compared to the different modalities of treatment for this kind of stone, between open surgery, PCNL, ESWL, and RIRS, PCNL as a single procedure would be the procedure of choice in Stagon calculus. Any stone about 2 centimeter in size, PCNL would be the choice of treatment, right? In terms of stone-free rates. But you would know that there is likely to be residual stones when you manage such large volume stone disease. What about metabolic workup?
Metabolic workup, we can advise for this patient, but
Can advise, will advise.
he's
What
already
would be your indications for metabolic workup in any patient with stone disease? Would
Sir,
you
in
invest?
pediatric
Will
age
we do
group,
metabolic workup in all patients, or you have a selective list?
Oh, sir. Selective patients, we can do, sir, metabolic workup. In case of
What would
pediatric
be your
age group,
indication for metabolic workup?
in pediatric age group, we can do a metabolic workup, sir, and repeated
Can do or
stone
will
for
do? No,
will do, sir.
there's a difference between can do and will do. In exam,
Will
you
do,
have to
sir.
be very dogmatic. You're a consultant material. You should be very sure of what you want.
Sir. In pediatric age group, we'll do a metabolic workup, sir. In repeated stone formers, we'll do a metabolic workup, sir. And in patients with bilateral stones, we'll do a metabolic workup, sir. And in the case of very old patients, also we'll do a metabolic workup, sir.
Yeah. In all Stagon calculi need metabolic workup.
Yes.
All stones with renal failure need metabolic workup. Patients who have got diseases which are prone to stone disease like gout, diarrheal
Yes.
disease,
Yes,
short bowel
Any congenital,
syndromes,
yes.
all these patients do require metabolic workup. So there is specific indications, and Campbell gives good good table is there in Campbell if you read it on what are the indications when you will do the metabolic workup, in whom you will do the metabolic workup. So in any case in the exam, examiners are bound to ask you a little about metabolic workup when you deal with stone disease. Okay. So you need
Yes.
to be very sure about metabolic workup in these patients. So like Dr. Sagar said, the treatment would be PCNL, bilateral. He is likely to require multiple sittings with multiple tracks, and you need to get rid of these stones completely because the chance of recurrence in Stagon calculus is very high. If you leave a focus of stone, they reform stones very fast, especially if they're infective stone. So your primary goal of treatment would be, one is to completely remove the stone. Second is get this patient off infection. So this patient needs to be monitored for recurrent urinary tract infection. And if there's a residual stone with recurrent infection, they develop similar kinds of stone within 6 months. So you should be very careful about managing these patients, get a stone analysis, and then take it forward depending on the metabolic abnormality. Anyway, this is the CT, this is renogram. Yeah. So I think we are closing to 30 minutes. So what we need to know in the learning objective about this case is, what are the imaging options that you have? Yes, I think both of you have discussed and answered that question well. That CT would be the optimum imaging of choice, with or without contrast, depending on his renal profile. Ultrasound could, of course, be used as an initial screening tool. There are options of using MRI. MRI, though it is very sensitive, but it's not very specific, it would be the investigation of choice in a pregnant woman, because you don't want radiation in pregnancy. So in pregnancy, after an ultrasound, MRI could be considered as imaging in a patient suspected to have stone disease. You need to know the various treatment options depending on the stone size, the stone burden, and the anatomy of the kidney and the location of the kidney if it's a congenital anomaly. You need to know the different advantages and disadvantages of each of the treatment options. That means in terms of complications, in terms of stone-free rates. So both these you should know very well, shockwave lithotripsy versus PCNL versus RIRS. So generally stones less than 2 centimeters, either RIRS or PCN or ESWL could be offered, if depending on the Hounsfield's unit. So you need to consider a lot of issues when you take treatment options. So not only is the stone morphology, the kidney morphology is also important, the size, etc. is important. So you need to look at all these parameters before you choose the appropriate treatment. You should know about the intraoperative complications and plan management accordingly, counsel the patient accordingly before you take the patient for any invasive procedure. In a patient with renal failure, they are likely to have more of hemorrhagic complications, and you should take adequate precautions to see that their hematological workup is done appropriately, and if required, cross-match a couple of units of blood and get them ready. In a patient whose creatinine is very high, who's unstable, he's got dyselectrolemia, one might need to consider a prophylactic DJ stenting or a PCN before you go and do a definitive procedure. Optimize the patient, get his creatinine down, get his parameters down, get his infection under control, and then do a definitive procedure. It might need to be tailored according to a particular situation, especially when you're dealing with the patient with a solitary kidney and a stone, or a stone, or a patient who's got significant renal failure. Follow-up is very important in terms that you need to get his cultures regularly monitored, see that he's infection-free, and any recurrence or need to be picked up early. Otherwise, these patients can develop a recurrent stag-on very fast. It's important to know all the indications for metabolic workup, do a stone analysis, and in which patient and how to do them is very important to know. If there are any questions, we will be happy to take them. Both Sagar and Nikhil, you have done fairly well. Just brush up on your theory a bit, and you should be very crisp in answering. Thank you for participating.
Thank you, sir.
Thank you, sir. Thank you. Thank you, Dr. Ramesh. Thank you, Nikhil and Sagar. I think, Dr. Ramesh, there are a few questions in the chat box. Before you sign off, you can just answer them.
Yeah,
and Nikhil and Sagar and other agents, it's very important to make note of the finer points which he has mentioned. And probably these finer points fetch you little better scores when you are compared with the other candidates. Thank you, Dr. Ramesh, again. We move on to
the question is what could be the reason for you?
Sir, you can type them in the chat box only. Yes,
okay.
We'll move on to the case 2. Yes, sir.
Please.
May invite the examiner for the second case, Dr. JVS Prakash, and the regents for case 2 is Krunal, Mahendran, and Rishabh. Please keep your video and audio on. Over to you, Dr. Prakash. Please take over.
Good morning, sir. Can you hear me, please?
Yes, sir. We can hear you, sir.
Can you hear me and can you see me?
Yeah, we can see you and we can hear you. Please share your presentation.
Good morning, sir. Good morning, everybody.
Good morning, sir.
Good morning, sir. I would like to thank Dr. Chawla and Dr. Keshav, the USI, for giving me this opportunity to be here with you. We'll straight away go to the case. Who are the people who are doing the case with me, sir? Mahendra? Yes, sir.
Krunal, Mahendra, and Rishabh.
Okay. So now you are giving, I will just tell you a short history. He's a 34-year-old male with VIU done for bulbar stricture 1 year back. Now he presents with severe voiding symptoms, IPSS 25. Want anything further in the history? Would you like to ask some questions in the history now?
Sir, I would like to ask more detailed history about the patient, why he has done VIU at the first place. What is the etiology? So to rule out that is
primary etiology. Yes, good.
Yes, sir. So has he had any episodes of urethritis or any history of trauma for this patient?
Yes.
Any past history of stone surgery or any other urological intervention before that?
Okay. Then anything else you want? Yeah.
Any history of UTI?
Would you like to know about the previous urethrogram and Euroflow studies?
Yes, sir.
Yes, sir.
Yes, sir.
Yes. And you would like to know the operative notes, isn't it?
Yes, sir.
What they have
Yes,
done.
sir. Yes, sir.
So then was he normally voiding after you? You want to know
Yes, sir.
about
What
that also?
Was he on self calibration?
Yeah.
Yes, sir. And this
Those are the
follow-up
things.
period or what?
And the most important is, when did his symptoms start after surgery?
Surgery. Yes, sir.
Okay, these are the symptoms. These are the questions you should keep in mind to ask the patient.
Yes, sir.
Okay,
Yes, sir.
most important, but not the last but not the least, is history of ED. You should never forget that.
Yes, sir.
Okay, you will realize the importance as we go across the discussion. Now, so next point is the examination is normal. Okay. Now the next slide. Now, what would you like to have? What would you like to do next?
The next I would like to have Euroflow.
Sir, urine routine
You would like to do the
examination
basic
and
investigations, right?
Yes.
Basic
Yes.
investigations. Yes, yes.
Urine.
So blood investigation is normal, urine is normal. Okay. Now what will you ultrasound? He says prostate is normal, PVR is also normal. Any other things you would like to see in the prostate and the ultrasound?
So kidneys, sir.
Excellent.
The bladder.
Want to look for the aqua tract pathology, if anything? Anything else?
Bladder. So
I want
bladder.
to see the bladder.
The bladder morphology. Is it bladder wall thickness? Is there any secondary changes like vesicle calculus or diverticular formation or anything like that?
Excellent, excellent, excellent. Okay. What about post-void urine?
PVR is also, but it's mentioned normal, sir. PVR.
it is normal.
Yeah. So you have to see the significance of post-void urine.
Yes,
We'll
sir.
discuss it. We'll discuss it a little later. What do you want to do next?
Euroflowmetry.
The Euroflowmetry.
Urine
good.
culture also needed. Sir.
Urine culture is normal.
Yes, sir.
Normal, yes.
Yeah. Please read the report, one of you. Please interpret the report.
So it is a box
This
pattern
is-
with.
One of you,
Sorry,
one of you.
So it is a box pattern which is suggestive
Yes.
of obstructive pathology in the urethra. The Qmax of 6.9 ml per second.
Now you have been given some values. Voided volume of 224 ml. What does it
Yes, sir.
indicate?
Sir, it is
Adequate
voided volume is
volume.
normal, sir.
Normal. What is the normal voided volume?
Sir, for Euroflowmetry, it should be more than 150 ml. So
Adequate. Is
adequate.
it what is the latest guidance with regards to voided volume? It is 100 ml.
200 to
It's 100 ml.
yes, sir.
Yes, sir.
Okay. When should the
Yes, sir.
patient void during Euroflow?
Sir,
Pardon,
When
sir?
should the patient void? You are asking the patient to hold urine. Okay.
Yes, sir.
Yes, sir.
When will you say that you are ready to void? What instructions will you give the
The
patient?
patient, we should tell the patient to have, he should void when he has the normal urge to void, not
Exactly.
severe
The first
urgency.
sensation to void. You should not ask
Yes,
him
sir.
to hold the urine for a longer period of time,
Yes, sir.
because if you have a very distended bladder, the urine will become slow. So the
Yes,
flow
sir.
will automatically slow down. So that is the fallacy. Okay.
Yes, sir.
Next we'll come to Qmax. What is
Yes,
the
sir.
normal Qmax in this gentleman who is 32 years old?
So it should be more than 25
Yes, sir.
for this age group.
More than?
For this age group, sir, it should be more than 25 ml per second.
No, doctor. That is too much. The 15
More
ml
than
is considered to be
15.
normal. Anything less than 15 ml is considered to be low flow. Okay. So what is the significance of post-void? Peak flow, and what are the fallacies of peak flow rate?
in case of
See, the
abdominal
peak
voiding,
flow-
sir, abdominal
Peak
staining.
flow is only a single value which shows the peak value of the urine flow, which could
Yes,
be
sir.
because of your abdominal pressure also.
Yes, sir.
Yes, sir.
So that is why you use the average rate.
Yes, sir.
Okay. Average rate is 4.6 ml. What is average rate? Could you give me what is the average rate? Definition of average rate. It is voided volume by flow time. That is the definition of average rate.
Yes, sir.
So it is more indicative of obstruction. Okay.
Yes, sir.
Yes, sir. Yes, sir.
Now, PVR here it is 55 ml. How do you, what is significant PVR? How do you say PVR is significant or not?
So more than 100 ml.
No, is it an arbitrary value or is it something to do with the voided volume?
Should be more than 1/3 of voided volume. Sir.
Yes, yes, yes. Okay.
You have to
In
take
this
some
case-
2 to 3 measurements. Not
Yes.
you cannot decide based on only one.
Exactly. In this case, PVR, even though it is 55 ml, less than 1/3 of the volume, still it is considered significant. Okay.
Yes.
Could you tell me some more patterns in uroflowmetry apart from the box type for stricture urethra?
So normal is the bell
Yes.
shape. Then delayed
Yes.
bell shape is for BPH. Or
Yes.
then intermittent pattern seen in hypocontractile
Yes.
bladder, and staccato
Yes.
pattern seen in young children
Excellent.
with the
Excellent. Excellent. What next do you want now?
sir RGU with MCU.
RGU and MCU. Which you will do
Yes, sir.
first?
RGU. Sir.
RGU, sir.
RGU. Okay. Okay. One of you comment.
This is a
Rishabh.
RGU study of
Go ahead. Go
It's
ahead.
like distal bulbar structure. Pinobulbar junction structure, sir.
Doctor, this is not the way. This is not the way you talk about the urethrogram.
this
Would you
is
like to have
34 years.
something else before? Would you like to have something else before you see this picture? Would you like to have a scout film?
Yes.
Yes, sir.
Yes, sir.
What is the importance of a scout film?
Sir, any radio opaque shadow in the like stone or anything that
Exactly.
Also to look for the fractures. Sir.
Okay, fracture, and you should look for the callus. Okay.
yes, yes.
Okay. And how is the ascending urethrogram done?
It should be, sir. First of all, patient should be infection free. We should have a urine culture. If it is sterile, we can go ahead with the procedure. Patient means we need to insert the 6 French catheter up to the navicular fossa and inflate the balloon 2 to 3 ml.
6 French is very small. 6 French catheter you are getting. You get it in your. You do. Is this the way you do? This
Sir,
is the way you
in
do.
our we have, sir, 6 French.
So patient should lie
Or
supine,
deep
sir, with the hip tilted, sir, with ipsilateral hip abducted, sir.
Exactly.
Penis has to be stretched, sir.
What
So
is the
it can
angle
be
of the
done-
hip? What is the angle of the hip? 45 degrees. Okay.
Yes, sir. 45
And it should be bent at the knee.
Yes,
Upper
sir.
leg should be stretched straight. It can either be
Yes, sir.
left lateral or right lateral. Okay.
Yes, sir.
Before
That is the position. How do you know that the position is correct? You think this
we
urethrogram,
have
the
the
position is
greater
correct?
so yes, a greater trochanter of this.
No.
You can see
Obturator foramen should not be visible on one side, on the side of the tilt. Okay.
Yes, sir.
Okay. If both obturator foramen are present seen, then it means that the position is not correct. Okay.
Yes, sir.
Then you have to do a urethrogram. So how much of what is Mardi Gras sign? Mask sign, Mardi Gras mask sign. See, this is nothing but in case the position is not proper and you are seeing both the obturator foramina, it looks like the mask, you know, when the people in Spain, they wear a mask for those Mardi Gras function. So that is called a Mardi Gras sign.
Yes, sir.
So that indicates that it is not been positioned properly. Okay. Now, how much of contrast you will inject into the urethra?
100 ml.
100 ml.
50
15
ml.
to 20 ml. 20 ml.
Doctor, anything between 20 to 50 ml. Okay.
50.
And how will you introduce the contrast?
So by two methods, sir, either through insertion of a small size pulleys and inflation at the navicular fossa, or by
Yes.
use of a clamp, sir, Rodney's clamp.
Yes. Yes.
You have to
How will you
slowly
inject
start
it? You will do a static film, or you will inject it under fluoroscopy?
Sir, first we need to have a static film, sir.
Static.
Initial studies. After complete injection of the contrast, sir. If it is not
Will you
adequate,
inject-
we have to inject still more, sir.
Will you
If the
inject?
bladder is-
You will have to inject it under fluoroscopy, preferably, because
Yes,
you will know then only know you will know the distensibility of
Yes,
the
sir.
urethra.
Distance,
Also whether it
sensibility.
is
Yes.
extravasating or something like that. Okay, so you should use gentle force and keep on distending. Keep on injecting the solution, the contrast till you see it enter into the bladder and the bladder fills up adequately. Okay.
Yes, sir.
What is the significance of stretching of the urethra?
To obliterate that penoscrotal junction, sir.
Exactly.
That
So that you will
shape has
get a
to-
proper picture. Okay, if you don't stretch the urethra adequately, there will be kinks and you will not be able to see the stricture area properly. That is the reason why you stretch the urethra. Okay, now comment on the picture. Where do you think the stricture is?
The proximal bulbar urethra.
Mid to proximal. Mid and proximal bulbar.
Mid and
Distal
proximal
bulbar.
bulbar. Proximal
Yes, sir.
bulbar.
Yes, sir.
No. You tell
Distal
me
bulbar,
where the penis. You tell me the anatomy now. Where the penis is, till where the anterior urethra is. Where is the bulbar urethra? Where is the membranous and prostatic urethra? Landmarks.
So
Okay.
from the penoscrotal junction to the lower border of the obturator foramen, that is the bulbar urethra. Above that, at the lower border of obturator foramen, it's the bulbomembranous junction.
See, doctor,
And,
this is the penoscrotal junction, right? Okay.
Yes, sir.
Then this is the
distal bulb.
Penile urethra and then bulbar urethra.
this is the bulbar urethra. Then you have the
Yes, sir.
proximal urethra. Okay.
Okay.
Fine. So now where do you think the stricture is?
Penobulbar region.
Distal bulbar. Okay.
Yes, sir.
Yes, sir.
You agree with me?
Yes, sir.
Yes.
Distal bulbar. Okay.
Yes.
Then what do you want to do next?
Sir, it's a failed VIU. It's a recurrence stricture. So we should counsel the patient regarding the.
You asked for one more investigation, no?
MCU, sir.
MCU.
Yes, sir.
How do you assess the length of the before going to the MCU? How do you assess the length of the stricture?
By comparing it with the length of the pubic symphysis.
No. See, you would have seen in some textbooks where they would have given a scale.
Yes, sir. The lateral side.
There'll be a scale either in this axis or this axis. Okay. So with that only you can measure. You can't put a scale and measure from here to here. Okay. From here to here, you cannot put a scale and measure. You will not get the proper length of stricture. Because this is very important, because the entire treatment options depend upon the length and the site of the stricture. Okay.
Yes, sir.
So always, how much do you think is the length of the stricture now?
So approximately 1 to 1.5 centimeters.
1.5.
Almost 2 centimeters, sir.
2 centimeters.
The stricture extends from here to right up to here, right?
Yes, sir.
Yes, sir.
You agree with me or not?
Yes,
Yes, sir.
Okay, right. Now we'll go to the next picture. That is the. So why should you do a cystogram? Voiding cystogram.
To see the posterior urethra.
Yes.
And,
You have to see the
Also look
bladder.
for
You see the
the-
bladder profile. You'll see the posterior urethra opening up.
The bladder
Then
neck.
what else you'll see?
The bladder neck.
Any associated reflexes
Bladder
there
neck.
also you can see.
Yes.
Any other strictures, sir? second stricture. Beyond this,
More importantly, why are you doing it? For most important point, you're not coming out. To assess the length of the stricture, no?
Yes, sir.
yes.
The proximal extent of the stricture can be delineated by using the MCU. Okay.
Yes, sir.
Next, what do you want to do? How will you proceed now?
So since the patient is
What are the options before you for treating this patient? Case of distal bulbar or bulbopenile, whatever it is, urethra.
Yes, sir.
What are the options you have?
So we
Either
have,
one
sir,
more VIU, sir,
Sorry?
or upfront buccal mucosal graft urethroplasty, sir.
You want to do a buccal mucosa substitution urethroplasty.
Yes, sir.
That's what you mean.
Substitution urethroplasty, sir. Or one more VIU also we can attempt, sir, after explaining the patient.
What is the criteria for doing a second VIU?
so it should be less than 1.5 centimeter, and there should not be any spongiofibrosis.
Okay, but it's already operated once. For the second,
Once operated.
so what is the criteria where you can say that you can operate it for the second time? VIU for the second time. Should be more than 6 months duration. So if the recurrence occurs within 6 months, then he is not fit for VIU.
Yes.
yes, sir.
But what is the other option you have apart from VIU? He said substitution urethroplasty. Is there anything else you can do?
Upfront dilatation.
Yes, sir. Non-excisional end-to-end anastomosis.
You can. What about end-to-end anastomosis? You want to do end-to-end anastomosis, small stricture, 1.5 centimeters.
We can do this.
Yes, sir.
You can do, or you should not do.
Should not do, sir.
Right.
Failure rate is more, sir. When we go close to the penile urethra, sir. This is.
So if the penile urethra is involved, what are the complications you can get if you do a urethroplasty?
Cordy.
Penile urethra, sir. Cordy is more.
Cordy.
Exactly. So
Young patient.
now, I would. Mahendran has given the right answer by saying that he will do a substitution urethroplasty. Okay. For the simple reason, this is a young patient, 34-year-old, does not have any history of ED, is sexually active. So, reasons why you do a substitution urethroplasty and not an end-to-end urethroplasty in these cases are because you want to prevent ejaculatory dysfunction, you want to prevent shortening of the penis, you want to prevent cordy, and you want to prevent the decreased gland sensitivity. These are the when you transect the urethra, you'll be injuring the nerves. So that will cause decreased gland sensitivity. So mostly the sexual issues should be addressed. And this is the reason why buccal mucosa or a substitution urethroplasty scores over your traditional end-to-end urethroplasty. VIU in this case is not advisable because we want to give him a good quality of life. With if you do VIU and he keeps coming every 6 months or 1 year for repeat procedures, then his quality of life is disturbed. So that is the reason we want to go in for a definitive procedure for which substitution urethroplasty will be the right choice. Now, what are the principles of urethral anastomosis?
Tension free.
Yes.
So, one person tell me.
Mucosa, sir, it should be tension free and
Exactly.
Mucosa to mucosa position.
Yes.
So proper bulbar mobilization. We should lift
those
the
are all
bulb
the
from
principles. One is it should be tension free. That is right.
Okay.
Two is mucosa to mucosa alignment. Correct.
So spatulated this well spatulated?
Yes.
Ensure adequate vascularity, sir.
No. See, there are the most important principles are, one is it should be a watertight anastomosis. It should not be under tension. It should you should use absorbable sutures, and you should stent the anastomotic site by means of a catheter.
Yes, sir.
Okay, these are the founding principles, the basic principles of urethral anastomosis, any urethral anastomosis. Okay, so now you want to do a substitution uteroplasty. What step could you just in brief tell the steps of substitution uteroplasty? Mahendran, any uteroplasty? What uteroplasty you prefer? You want to prefer
Sir,
dorsal
I
onlay?
prefer, yes, sir, dorsal onlay, sir. Kulkarni's technique, sir. Lateral mobilization.
Kulkarni's technique, that is lateral dorsal onlay.
Yes, sir.
What is the material you will use for substitution?
I will use buccal mucosal graft, sir.
Buccal mucosal graft.
Yes, sir.
Okay. So you know how to harvest the buccal mucosal graft.
Yes, sir.
And how do you assess how much of a graft is required? Length of the graft. How do you assess?
You can use scales also, sir, on silk threads.
Okay. So, okay. Before you do all these things, you have forgotten one important step. Would you like to do a cystoscopy on this patient? Ureteroscopy. Is a ureteroscope.
Sir, at the time of urethroplasty, we can do assessment.
Yes, you have to do a scopy to assess the
posterior urethra.
Length.
Proximal urethra.
And see if it allows a 6 French ureteroscope. This
Yes,
picture allows a 6 French ureteroscope. Okay, that is the point. Then you can do a buccal mucosal
substitution.
also lateral Kulkarni technique. That's what you want, right? That's what you want to do. Why do you want to do a lateral anastomosis?
So it has the same results, sir. It has reduced morbidity in comparing bilateral mobilization and proper dorsal onlay. And
Yes.
complications are less, sir. Success rates are more.
What is the main reason why you are not mobilizing the entire urethra?
To preserve vascularity.
Exactly.
Yes,
So
sir.
you want to preserve the vascularity. That is the reason
Yes, sir.
you are doing it on a lateral side. Okay. Now, what is the role of
Prakash,
urethral
3
calibration?
minutes left. Prakash, 3 minutes left.
No, sir. I have 6 minutes, sir. I am running the timer.
Okay,
6
go
minutes
ahead.
more.
Go ahead.
Yeah.
The proximal urethra should be calibrated to 26 French, sir. At least.
Yes, exactly.
Distal
What
can be 22
proximal
French.
urethra is 30 French. Distal urethra is 26 French. Okay.
Yes, sir.
So that is how you do it. Okay. And what about post-operative care? Early post-operative care. What will you do? What is the most important point? Most important point is because it is a long duration stricture, you are putting the patient on an exaggerated lithotomy position. If the operative time is more than 4 hours, then you should look for compartment syndrome.
Yes.
Severe leg pain. Okay, that is very important.
Yes.
Though it is very rare, it is an important complication which you should not miss. Second is you have to give anticholinergics to prevent bladder spasms and erectile and suppression of the erection. And then for the mouth, you can just give some ice packs and give some lidocaine oral wash to decrease the pain. Ask the patient to take soft, bland diet so that for a couple of weeks, so that mucosa heals properly.
Yes, sir.
Then could you tell me anything about the post-operative follow-up?
Sir, pericatheter study to be done, sir.
When will you do?
4 to 6 weeks, sir.
2 to 3
3
weeks.
weeks.
2 to 3 weeks.
Third week.
2 to 3
Third week
weeks.
is pericatheter study. If it
Yes,
is
sir.
normal, then you can remove the catheter.
Remove the catheter.
If you feel that it's not healed properly,
Yes, sir.
you can wait for about another 1 week
4 weeks.
before you remove the
Yes.
catheter.
Yes.
Okay.
Yes, sir.
Then you do an Euroflow and a PVR after
3 months, sir.
3 months. Exactly. Excellent. And cystoscopy, when will you do?
That's at 6 months.
6 months. One cystoscopy at 6 months, one cystoscopy at 18 months. And because if you are using substitution erythroplasty, you have to do a cystoscope. They say it's better to do a cystoscopy once a year.
Yes.
No definitive guidelines. These are the approximate guidelines which you have to follow.
Yes.
Okay. This is for the follow-up. The take-home message is principles of erythroplasty. I once again want to reiterate, this is the most important for a good successful erythroplasty. It should be tension-free, watertight, absorbable sutures should be used. The anastomotic site should be stented by means of a catheter, and cystoscopy of the proximal urethra before anastomosis to prevent anastomosis in the false passage. This role of second IU when recurrence is after 6 months. There's no role for third IU. Early post-op care and follow-up are of significant importance in preventing recurrence and improving outcomes. So now I have a short algorithm for bulbar urethral strictures. Short and proximal. Okay, you can do either excision and primary end-to-end anastomosis or a non-transecting erythroplasty, as Dr. Mahendran has just said. And if it is a long proximal and long or mid-distal, then definitely there's only role for substitution erythroplasty. So if there is no tight segment, that is if there's no obliteration, that is a 6 months ureteroscope can enter, then you can do either any of the onlay procedures, ventral, dorsal, lateral, or if there is an obliterated segment, then you go in for an augmented anastomotic erythroplasty or a double-sided dorsal and ventral graft. So this is in short the management of your bulbar urethral strictures. If you have any questions, please go ahead.
Yeah, Dr. Prakash, there are a few questions in the chat box. I think you can type your responses to those questions in the chat box. We'll go ahead with the next case. Thank you very much. Thank you
so much.
Rishabh and
Thank you,
Purna.
sir.
We move on to the
Doctor.
case 3.
Thank you, Dr.
Thank you, sir.
Mahendran and Dr.
Yes, sir.
Purna.
Thank you, sir.
Thank you.
Yes, sir. Thank you, sir.
Dr. Parth, Ujjwal and Madassar, please keep your audio and video on. Now I'll invite the faculty examiner for the case number 3, Dr. Mayank Mohan Agarwal. Over to you, Dr. Mayank.
Yes, sir.
Yeah. So you have Mudassar, Parth and Ujjwal.
Yeah. So good morning. Thank you, Dr. Arun USI, to giving me this opportunity. I'll try to keep it simple and straight. Yeah. Is can you hear me?
Yeah, you can hear you.
I'll come back in a couple of 1 minute, sir. The computer is hanging. Just I'll come back in a minute.
Sure. Okay. Kiran,
Yes, sir.
we have Dr. Venkatesh Krishnamurthy online.
1 second, sir. I'll just.
Yeah.
Not yet, sir.
Okay. I think Balagopal is there. Balagopal. Bala?
Sir, I'm
Yeah,
yes, sir,
Dr.
yes, sir.
Yeah.
I'm here.
So I
Yeah.
think Dr. Mayank is taking some time to just sort out the connectivity issues on the laptop issues. We'll go ahead with the other case, and this for this case we have a faculty examiner, Dr. Balgapan from Kochi, and the residents will remain the same. And over to you, Dr. Balgapan, if it's okay.
Yes, sir. I'll
Okay,
just
please
start
go ahead. Please go. Oh.
Start sharing my screen. I'm audible and my screen is also visible to everyone.
Yeah, full screen you can make, then we are ready to go.
Yeah. So this is our, at the outset, I would like to thank the ISU for this opportunity and congratulate them for whatever they are doing for our residents. So to begin with, the history is like this. It's a 5-year-old boy who was brought by his parents with the complaint of not finding the testis since early childhood. That is before 1 year of age. He was evaluated by local physician and advised to observe for some time. So, listening to this, what is your opinion about it? Any other relevant history that you would be interested in knowing? And how will you proceed?
We would like to know, sir, whether the testis comes down indefinitely or it's persistently
Okay, that's good. Yeah, there may be like a retractile testis.
Is there any hernia associated with?
Okay, sure. That is in the physical examination, whether you want to, that comes in the physical examination. This is with respect to the history. And what I wanted to know is like whether the child is term or preterm. Because the importance of that comes whether it's a preterm, because the chances of spontaneous descent is more, and the chances of having an undescended testis is also common in the preterm children.
And the birth weight also, I would like to know.
What? Pardon? I didn't
is he low birth weight or?
Yes. Another thing is like family history, although it's not very clear, but then yes, there are chances that other siblings. So all those congenital anomalies that probably are the pediatric cases that you get, probably you ask for the family history because, or the sibling history, whether it is the same thing is there in the family. Because like in undescended testis, and parents the father may be affected, or like the brothers or siblings, whether they are twin brothers, the chances is also high. So that is one thing about the history, like any other associated findings or the family history or the preterm or the birth weight and all that. Now, how do you like to proceed?
Like through the examination, sir.
Examination. Okay, so examination. Before we go into this thing, what is the normal position of the testis?
It's below the mid of the scrotum, sir.
What is below the mid of the
scrotum? The testis are if the testes are present below the midline of the scrotum.
Yeah, you're right. But like to be more specific, you should say that the mid part of the testis is at the mid level or below the mid part of the scrotum. So you define that mid testis to be at or below the mid part of the scrotum to be the normal position of the testis. So now in this case, I think the most important thing is, like, rather than the investigations and all, a systematic physical examination. So how will you go ahead with the systematic physical examination in a case of undescended testis? What all would you look at? You just take your time and like a systematic physical examination that when you are given a case, will you go through?
On inspection, the scrotum in general should be visualized. Visually looking empty scrotum. The rugosities over the scrotum should be visualized if they are present or not. Any inguinal or inguinoscrotal swelling is there or any bulge is there on inspection, it should be visualized. And we should also have a look at the external genitalia.
Yes. So what is the thing that you would look at the external genitalia? What do you want to look at the external genitalia? External genitalia includes the penis, the testis, and yeah. So what is there that you're looking at the external genitalia?
We should also take a note of the penis.
Penis. What? Be a little bit more specific on that. What is?
We'll see the meatus of the urethral meatus. Is it hypospadias? Is there associated with it or not?
Yeah.
And I would also, if the testis is not in the scrotum, then I would look for any other position in the inguinal canal also. Or is there, if it is not there also, then I will look for any ectopic position of the testis.
Okay. So
And the position should be, the legs should be crossed and the legs folded up so that the cremastic is obliterated, and then re-examine the testis.
Yes. So basically for examination, it is a supine position abducted because the chances of having the cremastic reflex is less if you are, or if it is in the standing, then probably with cross leg, that is what is mentioned. But usually we all examine them lying down. And then the penis, as he mentioned, the hypospadias. Anything else in the penis that you would like to know?
Stretched penile length.
Yeah, to see how the size of the penis is, whether it's a micro penis, and look at the opposite testis, whether it's there or not. The micro penis and all these things some importance in case of bilateral undescended testis, which has got its own importance. So now you said you would like to examine. One of the important part is to have a warm hands. Some people say soap and all, but yes, usually warm hands is what is required. And then the systematic, what are those ectopic locations that you are expecting the testis to be?
So most common location. The most common location of the ectopic testis is the suprapubic region. Other locations are
what is that suprapubic region? What is that? There is some term. It is called the suprapubic position. That is
near the superficial inguinal ring.
What is that? There's something we say. What is it? Superficial inguinal pouch.
Yes, sir.
Okay. So, okay. What are the other locations that you would find it? Where you will be looking at? In the Campbell, you have a very nice diagram of that. If you can go back and see that.
Femoral canal.
You can see, femoral canal.
Yeah. In the
femoral canal, root of scrotum, contralateral scrotum, superficial inguinal pouch already told, and rarely perineal.
Perineal, and one more, prepenile.
Prepenile.
Yes.
Okay. Okay. So in the physical examination is the most important thing. You have to have a systematic physical examination. When somebody asks the position where you have to have a warm hands, and then you start with looking at all these areas, and along with that, that is all these areas that we have mentioned. The genitalia, the penis, whether there is an associated hypospadias, if the hypospadias is there, whether it is a mild hypospadias or it's a severe proximal hypospadias, what's the length of the penis, whether there is an associated micropenis which is associated. And then you should also do an abdominal examination also and spine, because there are many other anomalies. About 500 anomalies are associated with undescended testes. But look at those common things: abdominal wall, prune belly. So these are the rarer things, but yes, you can mention about that in your examination. So what are the different forms of cryptorchidism that you know of?
Sir, it is divided into unilateral, bilateral, and palpable and non-palpable.
Yes, that is the most common thing. Yeah, unilateral, and that is the, yeah. What are the other forms of cryptorchidism? Okay, so I'll just answer that for you. The other forms, yeah. Anybody is there?
Acquired.
Now there is.
Sir, primary and acquired.
Okay, so yeah, there is one thing which is the, as you mentioned, it can be unilateral or bilateral. There can be a palpable or non-palpable. That is the part of that. But when I ask you what are the different forms, it is either syndromic cryptorchidism, or that is the normal congenital cryptorchidism. There can be an acquired cryptorchidism. Acquired cryptorchidism is when the testis is usually low at birth. It may be a high scrotal, but as they grow, it can go back. So acquired cryptorchidism is something which is an entity which has been there and which is now it is coming into. The third one is the secondary cryptorchidism. The secondary cryptorchidism is post-surgery, like a hernia surgery or an orthopexy has been done due to scarring. It can again go back in. So these are the three forms probably that you should know of. So how do you differentiate an undescended testis from a retractile testis?
So from the history, patient mother or father will tell sometimes the testis is, when he is sleeping, the testis is in the scrotum, and on touching, the testis goes back into the inguinal canal. Second, we can appreciate also in the cross-legged position, as we told. We can, after obliterating the cremastic reflex, we can feel the testis below also in the scrotum. On touching, the testis goes back into the inguinal canal.
So the thing is, when you examine, like you're right, you examine them properly, you milk that testis down gradually and hold it there for some time. And when this and repeated examinations, if it stays there in the normal position that we discussed earlier for even a few seconds, then the chances of it being a retractile is. So this coming back, if it's bilateral undescended testis, palpable or non-palpable, anything particular examination that we discussed, it's basically the genitalia that you have to look at. And the importance of the genitalia is in the discussion part, that like if it's a hypospadias, like if it's a severe hypospadias and bilateral undescended testis, then the evaluation goes in a different route. Similarly, you have to answer that. So what are the investigations, if at all, that you require next? In this case, that's a unilateral, non-palpable, undescended testis. Any investigations that you would like to have?
So apart from routine investigation, I would like to do ultrasound abdomen.
What do you want to know?
So since the age of the child is 5 years old, so I will offer him surgery. So for that, I would like to do a urine routine examination and all the other investigation for the anesthetic checkup. Apart from that, ultrasound can, if the baby is obese and we are not able to palpate the test in the inguinal canal, then in that case it might help. MRI is another option, but it should not be offered because it requires anesthesia and it has its own cost.
Hello.
Yes. Yeah. Tell me. Somebody is speaking. Yeah. Hello.
Hello.
Yeah. Hello. Okay. So ultrasound. You said ultrasound. So ultrasound for a non-palpable testis, as you mentioned, if the body habitus is something like
Yes,
you cannot,
obese.
like obese child, it is useful. But for that matter, the role of imaging ultrasound per se for a non-palpable testis if the child is not obese, the sensitivity is very low. It's around 55, the sensitivity is around 55% and specificity is a little bit higher. So, but for an inguinal testis, if it's a palpable one, definitely ultrasound has got a higher sensitivity and specificity, which will tell you about the size of the testis. In spite of what the various guidelines recommend that there is not much role for ultrasound, but it has been found that in all over the world, ultrasound is done. Similar is the case with MRI also, and MRI will come into the discussion where it is useful. Like MRI also doesn't have much sensitivity in non-palpable testis, sensitivity or specificity. Any role for hormone evaluation?
Not in unilateral undescended testes.
Yes, not in a unilateral, but like where is it useful?
Bilateral
undescended testis. So bilateral undescended, bilateral undescended testis. So bilateral undescended testis, what all hormones will you evaluate and what is the importance of those hormonal evaluation?
Serum testosterone.
Yes, serum testosterone. Then what else?
FSH, serum FSH.
Yes, FSH. Yeah, so we have to rush into the video. We'll just go and I'll just tell you. It's basically, I will tell you that testosterone, FSH, LH, these are being done without hypogonadism, particularly in cases like where there is lateral norchia, some like intrauterine torsion or vanishing testis syndrome. So you get, if you have a bilateral undescended testis, which is diagnosed at birth, you have that safe window where you evaluate that hypogonadotropic hypogonadism. So you can start the hormone supplementation earlier. And this is one thing that is used. So the continuing on to the case, a USG inguinal scrotum was done and right testis could not be found. As I mentioned previously, like in spite of it being not recommended, we still do it. And on examination, the external genitalia is normal and the spine is normal and all other abdominal wall and all is normal. So what next? Okay. Okay, it's an undescended testis, so the next step probably would be diagnostic laparoscopy. So anything you will do prior to laparoscopy on the test?
So I will examine the patient under anesthesia, the inguinal canal. Is it now the testis is palpable or not? Sometimes the testis come down in the inguinal canal after anesthesia.
Yes, very good. So this physical examination under anesthesia is a very important thing, because if at many a time it's a peeping testis or with anesthesia, it may come into it, so you can avoid a laparoscopy. You can go ahead with that. You can possibly avoid a laparoscopy and you can just do it with an inguinal approach. So what can be the findings on diagnostic laparoscopy?
Can be either it can be peeping testis near the inguinal ray. Second finding could be that it's the intra-abdominal near the iliac vessels. Third could be a blind ending, and the fourth can be maybe entering the inguinal canal. Blind ending is ectopic.
It was little difficult to hear, but yes, you had some of those points. Like it could be a different scenarios which are found on the diagnostic, like a blind ending vas and vessels. What you do if it's a blind ending vas and vessels?
Nothing, sir. Just also.
That means the vanishing testis is there.
So vanishing.
Yeah,
So
so
that
it's a
shows
vanishing.
it's a vanishing test.
So there is a
Try to
high
find
chance
out.
that it's a vanishing test. Do a physical examination, see if there is anything in the inquiries. Very rarely they have mentioned that something can be there, but it is very unlikely. So was and vessels entering the deep ring, what do you do?
If they are
You can
normal
see-
vessels, then inguinal exploration should be done.
Yeah, so inguinal exploration is done and you find a nubbin of testis. What do you do?
Bring the testis down.
Remove.
A
So
nubbin,
we
a
will see
small
it's a
nubbin
bilateral or
is there.
unilateral. If other
should
side
be
testis is,
removed.
if one side testis is a Newman testis, very small testis, other side testis is normal, then you can go with the arterectomy on the atletic side, and on the other side you can do a orthopexy.
Okay, yeah. So if it's a nubbin, you can consider doing an orchiectomy. The chances of malignancy in these nubbins is very low, but still, yeah, it's better to go ahead and do a knock it off. A small atrophic testis is in the inguinal, in the abdomen. What do you do?
Opposite testis is normal, then it should be removed.
Yeah, so that's so all this probably one question that I would ask you before is that you should do a proper counseling of the parents considering all these scenarios that are there. So you should properly consider, because if they are not willing for an orchiectomy, you should consider bringing it down. So yes, atrophic testis, probably you should consider knocking it off. If the other testis is normal, there's chances of malignancy and it becomes difficult to manage it. Normal size testis, okay. Testis is not seen and vessels are also not seen. What would you do?
The possibility is that could be an ectopic testis, sir. Then we can come up and later here the role of MRI has been proposed. MRI angiogram can tell us where the testis is and the ectopic location.
Okay, so but you are having a diagnostic lab doing, the child is under anesthesia. Something you can do to look for the ectopic testis.
Perirenal area we should see.
Yeah, you should go into the retroperitoneum. You check behind the bladder. You should do a proper inspection behind the bladder, in the pelvis and in the retroperitoneum. Go in the perirenal area, dissect all the way up and see if you can find whether the testis is there. And as you mentioned, after this, even after this, if you don't find, to make, like after the laparoscopy, you're still not able to find, then as Mudassar mentioned, to go ahead with you can do an MR angio to just make sure that there is no ectopic, that the ectopic testis is not there. So what's your opinion about the medical management of undescended testis?
So beta HCG can be offered.
What?
So beta HCG can be offered to the patient if it's.
To whom can the beta HCG be offered? You offer beta HCG? Anything
So
else
less than
that is
5.
of that one? The medical management, beta HCG, LHRH, agonist, these were the things that were being used. So what are the current consensus or guidelines on this use of these?
There is no proven role currently for these agents.
Yes, you are right. There is currently not much role for any of these agents in the management of sensitive testis. Also, that I'll come up and cover in the next few slides. So, surgery. How will you go about it? Like if it's like it's a palpable inguinal. Now, it's a 5-year-old and under anesthesia, I find that the testis is palpable in the inguinal region. You can just mention can just elaborate on the surgery and the steps that you will take for bringing the testis down.
If it's the deep inguinal ring, sir, we can just make an incision there after mobilizing intraabdominally, and then we can dissect the lateral attachments and then bring the testis down after making a separate incision in the scrotum and creating the extratortus pouch, and then pulling it down and fixing it if possible.
So as you told,
you can just
the
mention
testis is palpable in the inguinal canal. So we'll give a transverse incision at the inguinal crease about 2 to 3 centimeters, and we'll dissect down. Then we'll incise the extra oblique fossa. Then we'll palpate the testis. Then we'll find the gubernaculum, and then we'll try to pull the testis. And then we have to divide the cremastic fossa. Then there will be a sac along with the processus vaginalis. We have to dissect all around. We have to separate it from the cord. Then we have to ligate it near the deep ring. Then we have to pull the testis down. If it is coming easily to the base of the scrotum, then we have to make an incision about 1 to 1.5 centimeter in the scrotum. Then we have to make a subdartos pouch. Then through the artery clamp, we have to make a passage from the inguinal canal to the scrotum. We have to bring the testis down. We have to fix it, fix the testis with a non-absorbable suture at the subdartos pouch.
Very good, Ujjwal. You answered most of it very well. So yeah, there have been controversies about fixation sutures through the testis, so there are other ways of fixing or retaining it. The most important thing is that you should not have a like a traction on the testis, because the chances of it, there is if it's under traction, so it should be fully mobilized, and the length, there are different. You have mentioned all the ways of lengthening the cord, including the removal of the cremastic fascia and the herdial sac. And Prentice maneuver, you all know Prentice maneuver. Yeah.
Yeah, in this case, I would like to add, sir, like we should avoid the torsion of the cord when we're pulling the testis down to the subdartos pouch.
Yeah, definitely, because the chances of one of the complications of undescended testis surgery is atrophy of the testis. One, because of the traction. Second, the twist or the and third is the suture. Suture, where you all need to know where it has to be taken. If you have to take it, where it has to be taken. Usually they tighten the neck of the neck through which the cord comes. No, they take it, or you can also use the sutures to the tunica vaginalis, that is the tunica vaginalis that accompanies. You can take through the dartos and the tunica vaginalis, retain them. And then Prentice maneuver, you can just shortly tell if it is, Prentice maneuver.
Mobilization of the testis medial, inferiorly and medial to the inferior epigastric artery.
Yeah. So that probably for the lengthening part, if the length is less, you can just incise the transversalis fascia and then bring it medial to the vessels. Also, you can do some retroperitoneal dissection by putting a retractor through the deep ring, and that way also you gain some length. So, yeah, something about Fowler-Stevens procedure. You know,
two types of stage 1 or stage 2. It can be done in 2 stages also. I mean, it's the principle is that the ligation of the testicular artery.
First of all, we'll see the testis is coming to the other side, deep inguinal ring or not. If it is coming, then most likely the testis will come down into the. We can bring the testis down in the first step only. If it is not coming to the other side inguinal ring, deep inguinal ring, then in that case we have to go for the second 2-stage operation. In that case, we have to ligate the testicular artery just above the testis, and after 6 months we'll come back for the second stage.
Okay.
It is ligating the testicular artery, letting the collaterals develop during a period of 6 months before the second stage.
Okay, so the collaterals come through the
artery to vas reference.
Artery to vas and cremastic.
Yeah, artery to vas and the cremastic. The collaterals come through that, and you have to preserve in the second stage, or even in the first stage, what will you do? Like if you do a Fowler-Stephen stage 1, that is single stage Fowler-Stephen, not stage 1, single stage Fowler-Stephen is also there.
Yeah.
So what is that?
Sir, as he mentioned, we'll see that we'll take the testes to the deep this near the deep, to across. If it crosses, that means the length is advantageous. We can proceed with the single stage. And other thing is, earlier it was said that high ligation of the, like away from the one centimeter away from the testis, but now the evidence says that it should be close to the testis, the ligation of the testicular artery.
Yeah,
So
good answer. That was my one of those questions, whether will you do a high ligation or a low ligation. You answer that. Initially it was high ligation. Now Koff has mentioned that low ligation near the testis is located. And the most important thing is the preservation of the peritoneal fold, which is the medial peritoneal fold while you do a Fowler-Stephen procedure. So I think all of you answered it nicely, and it was good. Some brief thing, all of you can go ahead with this AUA algorithm is there. It's a very good algorithm, which probably for exams as well as for our practice, it is there in the book. All of you can refer that. You can go through that. It is for the management, like if it's a palpable or a non-palpable. If it is bilateral non-palpable, then you should consider for a DSD, you should rule out DSD. And there is, if it's older than 6 months, then they should be corrected for gestational age and reassess after 6 months. Many a times, if it is preterms, they come down. So you can all go through that. Just to mention few things which you probably will, now you are going to have Hoskies, where like DNB is going to this year conduct again Hoskies. So some of those questions, testicular descent is regulated by the Leydig cell hormones, and you may all be knowing all this INSL3 and insulin-like hormone through its receptors, and dihydrotestosterone and testosterone through there, androgen receptor. And one of the important thing is an intact innervation of the pernaculum by genitofemoral nerve. And ultrasound and MRI is not recommended in non-palpable testis. It's higher sensitivity for inguinal than abdominal. As Mudassar mentioned, MRI identification for ectopic testis, not localized by laparoscopy. Additional they can ask you additional diagnostic testing in bilateral undescended testis. We should do mention karyotyping, and as we mentioned, discussed earlier, hormone analysis like all these LH, FSH, testosterone, that is AMH and inhibin, and chromosomal analysis also. So for usually observation for first 6 months for spontaneous disease and surgical treatment after 6 months, and preferably by 12 months of corrected gestation. So now earlier it was one question last that earlier it was like 2 years or 3 years. Now what are the current recommendations of doing undescended disease and why?
One year, sir, because only up 2% of the childhood, it will descend in only 2% beyond 12 months. So that's why 1 year.
Sir, I couldn't make out little bit echo there. You may have answered correctly. Anybody?
The current guidelines say that it should be the ideal age is up to 1 year only, but catch-up growth can occur till 3 years. After 3 years, catch-up growth will not occur. It should be properly counseled to the parents.
Yeah. So 1 year, what is that current thing? Like why that 1 year thing that they are mentioning? Why is it? What is there in
because after 1 year, there is very less chance, around 2% chance is there that it will descend after 1 year.
No, the chance is less. Anything else with the development of the testis per se? You can go back and look into the AD spermatogonia, the dark spermatogonia, no? Like which is useful for the fertility part. By 9 months, usually because after that, the chances of its migration or its development is less. So you can go and check on that. So hormonal therapy to stimulate testicular descent is not currently recommended, but like it can be used as an adjuvant treatment in bilateral undescended testis to improve the semen parameters. Thank you all. Thank you.
Thank you.
Thank you, Parth, Ujjwal, and Mudassar. Thank you, Balgopal.
Thank you, sir.
Thank you very much. And Bala, before you sign off, just look at the question in the chat box. You can type your answers, and we move on to the next case, case number 4. Is Mayank okay now? All set with his laptop? Mayank? Mayank? We have.
Am I audible, sir?
Yeah, audible. You have Mayank, Steve, Varun, and Shashank.
Yeah,
3
okay, sir.
residents for case 4 discussion. Steve, Varun, Shashank. Over to you.
Yes, sir. Yeah. Actually, yeah. Okay. So can they see my presentation?
Yes, sir.
Okay. Actually, I'm really sorry today that my laptop has really given me trouble. But anyway, I'll just make it. Yes. Yeah, can I? Is my screen visible? Hello.
No, not visible.
Not visible now. Oh my God. I know Dr. Arun will not document. Just give me one moment, please. I'm just coming in. Just coming in. I'm really amazed. Sorry for this. Just coming.
Arun, can you see if Dr. Venkatesh is there? He can finish his presentation.
Yeah, I'm ready, sir.
Unmute yourself, Arun.
Yeah, sir, I saw that he's not in the gallery. That's what I was looking at.
Am I audible now, sir? Am I visible now?
Yeah, you're audible. You're audible, Mayank. Audible.
The screen is visible now?
No.
Oh, but I shared it.
You can come back, stop sharing and come back again.
Yeah, okay. I'll do that. Models. Share. Now it must be visible, sir. Yeah?
That's fine, Mayank.
Yeah, okay. So thank you very much, and I'm really sorry for this mess up today. So I'll be presenting one case. So students, are you listening?
Yes, sir. Yes.
Yeah, so it's a 45-year-old gentleman, hypertensive. He was brought to the emergency with a history of gunshot injury to the upper back. And you had a urology referral sent by emergency department since he was unable to pass urine. So at that time, the physical examination, he had mild anemia. His BP was normal, 120/90, pulse was 105 per minute, saturation was 93%. He was completely paraplegic and bladder was palpable. So what would you like to do at this point? What is in your mind and what would you like to do at this point?
Sir, I would like to place a catheter periurethral.
So what's in your mind before placing a catheter? What do you think is going on?
It seems that he is suffering from post-traumatic spinal shock. That's why the bladder is palpable. So I will straight away go for the SPC placement.
SPC. Why SPC? Why not a urethral catheter?
Sir, the advantages of the SPC for the periurethral catheter is there because the spinal shock tenure usually takes the time for 4 to 6 weeks to come down. So SPC will give me the advantage of that it is related with the less chances of UTI. Compared to periurethral catheter, and in future, if I wanted to subject the patient for urodynamics examination, then I can do the filling with the SPC. That will be more physiological.
Anyone else?
Sir, I would like to place a periurethral catheter police in the initial stage in the emergency.
Okay, so why? What is your argument compared to what your colleague just gave? Putting of periurethral catheter compared to a suprapubic catheter.
For long term, yes, sir, suprapubic catheter is more needed because he can have an atonic bladder.
You just said periurethral catheter. So give me your argument of periurethral catheter compared to a suprapubic catheter. So why do you want to place a periurethral catheter? Just give me something. You said periurethral, you must have thought something. So tell me.
Routinely, initially we try for periurethral catheter. If it is not possible to pass, then I'll go for SPC.
Okay, so initially, because this is a acute injury, we would like to place a periurethral catheter. And periurethral catheter or suprapubic catheter placement for long term can be decided later. This is a very acute situation, and periurethral catheter is a recommended procedure. So before we proceed, why your colleague said spinal shock? So doctor, why do you think there is a spinal shock? What parameter thinks? What makes you think that there is a spinal shock? And what is a spinal shock?
Sir, here after post-trauma, there is a traumatic event. Number one, gunshot injury is there. And second is that there is completely paraplegia and the bladder is palpable. So I guess that after this traumatic event, all the neurological senses, motor as well as sensory will be lost below the line of the traumatic event. So that will be the cause for the spinal shock.
So basically to start with, any acute injury will lead to potassium, extracellular potassium collection in the spine in that region. So it inhibits all the neurological activity below the spine. So there will be a region of complete flexibility of bladder, bowel, and everything sensory motor below the level of injury. So this is called spinal shock. So how long does the spinal shock last?
Sir, usually it lasts for 4 to 6 weeks.
Okay, so it may last for from few days to several months. So there is no thing, but you said it right that it lasts for few weeks. So now his Foley's catheterization was done and his retention volume was around 950 ml, right? What are the other priorities of this patient at this point? I would say rather, what is the first priority of this patient? He's a gunshot injury. So as a doctor, what will you look in this patient?
Sir, I would like to check his vitals, repeat his vitals.
So vitals are all right. His pulse is
check his,
also acceptable.
Check his complete blood picture and hemoglobin, sir. Serial monitoring has to be done.
Yeah. So basically, it's a multiple, multi-departmental thing to be taken care of, and it is suffice to say because urology referral was sought. So his initial trauma ABCT has been done, and once you reach, it's your first responsibility to look at the patient generally. So as mentioned, his vitals are normal, mild anemia is there. You will look for chest and abdominal examination. Are there other priorities? Because catheterization is a nursing job and it can be done at the same time, but at very of by the nurse itself. But once you have reached there, so you should check the patient completely. What are the priorities for A, B, C, and D, and then you proceed for your Foley catheterization or whatever else for the urological examination and treatment, right? Okay. So once he was stabilized, his CT scan was done. which showed pellets in left lung fields, hemothorax, 5 to 7th rib and D6 vertebra with studded. So he underwent thoracic exploration and laminectomy, and now he's stable. There was no abdominal wound, and his retroperitoneal and peritoneal structures were intact. So in post-operatively, he is now stable. So what else would you like to know in the history? Because that was a acute trauma event. You would not like to ask a very extensive history, and you just did what you had to do. And perioral Foley catheterization was the right thing to do at that time. We'll come to that. So what else in the history at this point would you like to ask?
Now, sir, I'd like to ask whether he is ambulatory or not ambulatory.
Pardon?
And hello.
Yes.
Whether he is ambulatory or non-ambulatory. Whether he is able to pass the bowel or he is still constipated.
Okay. Anything else?
So previously, any urinary symptoms if he is suffering with, I would like to inquire.
So did he have any previous urinary symptoms or previous bowel symptoms which may have a bearing on the current symptomatology? Although he is paraplegic, it is expected that he is still in spinal shock and he will have severe bladder and bowel dysfunction. So an important point in history is to ask the patient's social support. You anticipate that this patient is a spinal shock and potentially a long-term dependent person. So it is important to know whether this person has a good social support or establish whatever social support he has. At this point, the patient will be very much demotivated. So as a part of history, you will like to know his motivation status. Although it is a psychiatric job to know if he thinks, but you can still give a motivation, positive reinforcement to this patient. So anything else in the examination? We haven't done a detailed examination at that time because the patient was in trauma. You just examined of ABCD, placed catheter. Now he is stable. So what examination findings relevant to urology would like to do?
Sir, I'd like to look for the renal angle tenderness, and then I would like to look for the genitalia, and like to do the distal rectal examination along with the focused neurological examination in this patient.
Okay, so what is the examination at this point? Focus examination.
Sir, on distal rectal examination, first of all, I'd like to elicit the anal, perianal sensations, the anal tone, whether the anus is loaded with the fecal matter or it is empty, and what's the bulbocavernous reflex. And then I'd like to look for the lower limb examinations in the power of in the matter of tone, power, and reflexes. And reflexes.
And reflexes. Very good. So in examination, he had lax anal tone. He was not able to sense anything. The fecal loading was present. BCR was absent. And deep tendon reflexes were absent. There was a complete flaccid paralysis of both lower limbs. There was no renal angle tenderness. Now, what else? So it corroborates with your diagnosis of spinal shock. Okay.
Sir, it means that the patient has not yet recovered from the spinal shock.
Yes. So it's at present, you don't expect him to recover in 3 days' time from spinal shock. So at present, you think that this patient is still in spinal shock, right or not?
Yes, sir.
Yes.
So patient is in spinal shock and it is corroborated. So what is a BCR? Just tell me more about BCR. And what does it mean?
Bulbocavernous reflex is a spinal reflex, sir. It is
how do you
the first reflex lost in spinal shock and the early one to recover in spinal shock. So
how do you elicit
elicitation is done by pinching or the penis and watching for the contraction of the anal sphincter, sir. Osinski sign.
Pinching of the what?
Penis, sir. Glans penis.
Pinching of the glans penis. Okay.
Yes, sir. And look for the anal contraction, sir. Anal sphincter contraction. Either by inspection, we see a wink reflex, or by palpation. When we put a finger, we can appreciate the contraction.
Is there any other way of eliciting the BCR?
As in
Because the patient already has a catheter.
I think your colleague
catheterized,
is
so
trying
we'll
to say
touch the
something.
catheter and we'll elicit for the BCR.
Pardon? Tell me again. Hello?
Sir, as the patient is already catheterized, so in this case, I will just tuck the catheter and I will elicit the BCR.
Okay, very good. So basically, bulbar cavernous reflex is a very important reflex to elicit at any point in any focused neurological examination of any patient with boiling dysfunction, whether neurogenic expected or not. So it gives you a lot of information on what does it inform you. If the BCR is intact, what does it inform you?
That the S1, S2, S3 spinal roots are intact.
S2 to 4 spinal roots are intact. Okay. So at this point, we have made a diagnosis that this patient is in spinal shock. He's still on Foley's catheter, which, let me help you, it says 14 French size of Foley's catheter. So how do you investigate further? What else do you want to know right now? Or how do you manage him? Any further investigations you would like to know?
Sir, I'll wait till the recovery of the spinal shock and then I will examine the patient.
No, examination you've already done. Now, what else do you want to do? So my question is, what other investigation would you like to do? And till when do you want to keep the Foley catheter in this patient?
Sir, I would like to do an ultrasound, sir. Ultrasound of KB region.
So this patient has already undergone a CT scan, and we know that there was no abdominal injury. Kidneys were normal. The bladder was normal at that time. So there is no need of any further ultrasound at this point, because you're not going to gain anything. It's just immediate post-operative status. So you want to. So my next level of investigation will be, once you tell me till when will you want to keep the catheter. Is there a role of self-catheterization at this point, or family-assisted intermittent catheterization at this point? So what is the role of CIC, if I ask you?
Yes, sir, if the patient is having a good dexterity or he is having a good social support from family, I would like to remove the catheter and would like to teach him self-catheterization.
Yes.
Do you agree? Do your other colleagues agree?
Because self-assisted catheterization will...
Voice is interrupting.
Sir, better option in this case will to go away with the SPC, sir.
Okay. So basically at this point, the question, the point of CIC would be, what do you expect in social support and what do you expect in the bladder behavior? So what do you think in spinal shock the bladder behavior would be? Will the compliance of this bladder will be good or bad in the acute phase?
The compliance will be good, sir.
Yeah. So if the bladder
patient will not be having much of the sensation of the bladder filling.
Yes. So if this patient has a good bladder compliance, that means the storage phase of the bladder is good. Then if this social support and motivation is present, it is always better to put the patient and the family on CIC, because that is the expected long-term course of action for this patient. Maintaining on a long-term Foley catheterization, maintaining on a suprapubic catheterization is basically a terminal event. When the family says, no, we cannot do a CIC, or the patient is not willing for it, then only you will proceed for a long-term catheterization and suprapubic catheterization. Suprapubic catheterization to start with in an acute setting, I will not suggest, and it is not recommended, because it is too early to it's too early to know what is going to be, for how long the spinal shock is going to last. Suprapubic catheter will give them a lot of convenience, and the chance of doing the CIC will be lost. You have punctured a bladder, you've done an invasive procedure. So suprapubic catheterization in an acute setting is not recommended. If at all, you would like to keep the patient on Foley catheter if they're still not motivated, and keep motivating them as soon as possible. And CIC is always preferred at this point. Now, would you like to do a urodynamics at this point?
No, sir. Still, the spinal shock has not resolved. So I will wait for the spinal shock to resolve. Then I will evaluate with urodynamics.
Okay. So what do you expect in urodynamics now? Why do you say that we don't want to do a urodynamics at this point, and only once this shock is resolved?
The patient doesn't have efferent supply sensation, sir. He won't be able to appreciate the sensation.
It will not come back even after the spinal shock is over. If there is a complete transaction, he will never gain sensations. So when do you want to do any investigation?
Sir, when the BCR reflex is present, it means that there is a recoverability from the spinal shock. At that point,
No, I'm talking about I'm talking about right now. Why would you not like to do urodynamics now? The answer is that at this point, doing or not doing a urodynamics is not going to change the management, because this patient is expected to have a good bladder compliance and a complete loss of all sensations and motor activity. So at this point, urodynamics is not going to add to your diagnosis. So that is why I will not do a urodynamics at this point. That's the answer for you. So I would prefer this patient to be put on CIC. If not possible, then keep him on indwelling Foley catheterization. So suppose this patient is put on indwelling Foley catheterization, right? So what do you tell the family how to take care of a Foley catheter at this point?
That proper hygiene of the catheter should be maintained, sir. It should be changed
How?
regularly.
Regularly means how frequently?
3 weekly, sir.
Okay. Does it depend on the type of catheter also?
It depends, sir. If I place a simple catheter, then it's need to be changed every 2 weekly. Otherwise, if I
simple means? Simple means?
Latex. He means latex.
Hello. Simple latex
Yeah,
catheter.
So it's a siliconized latex catheter versus all silicone catheter. So all silicone catheter can be left for longer period of time. So one is frequent changing, cleanliness, and what else?
And bowel hygiene, sir.
No, let's talk about catheter care only right now.
It must be taken care that it is close to his body, sir. By a plaster, we must attach it to the patient. Prevent the overweight. Yeah.
Prevent tugging of the catheter, prevent kinking of the catheter, and the bag should always be below the bladder level. Okay, so now we are urologists and we only take care of urine. So anything else you would like to take care of, or at least tell as a clinician? So somebody said bowel. So what else? What do you want to tell in the bowel?
That the fecal matter should not contaminate the catheter, sir. He should be given proper enema if he is not passing the bowel.
Yeah. So if he's not passing the bowel, so with or without assistance of your medical gastroenterology colleague, or maybe you yourself can start the medications for constipation. And perineal hygiene is of utmost importance. And to make sure that the patient passes stools at least twice or thrice a week by enema or by oral agents. We'll talk about oral agents later. So he was put on CIC. The family support was very well. And he was put on CIC every 6 hourly and other standard management. So he continued CIC, but he was lost to follow up from urology department for about 6 months. But he continued to come to neurologist, and he was never referred to urology. So after about 6 months, he came to urology for urinary incontinence. So he came with a history that he passes between CIC episodes. He has urinary incontinence. His urine has off and on smells and flakes, and is unable to pass urine voluntarily. He has severe constipation. He's wheelchair bound, and his medications are telmisartan, baclofen, pregabalin, and vitamins. So what do you think right now? So do you think that his spinal shock has resolved or not?
It has results.
Why do you think that is resolved?
He has
Why?
bladder spasms in between, so there is incontinence.
So basically, urinary incontinence is an indicator that his bladder compliance has reduced somehow. Now, whether it is because of overactivity or whether it is because of tonus, we don't know. That we have to find out. So incontinence itself means that his compliance is reduced and possibly the bladder motor activity is coming back. So in examination, what do you expect at this level of spinal injury? So you would like to do a focus examination once again. What do you expect?
On examination, sir, I will feel that the BC present in this patient, and also on the deep tendon reflexes, this seems to be exaggerated.
Okay. So he was afebrile to exam. He had minimum perineal sensations. The tone was decreased. BCR was present. Fecal impaction was present. And he had spastic paralysis of both limbs with exaggerated deep tendon reflexes. Okay. So you think that his spinal shock is gone, and possibly he is now developed bladder dysfunction. So what all is expected at this level? So one, you said it was overactivity possibly might have developed. What else would he have developed in the bladder or lower urinary tract function?
Detrusor sphincter dysenergias.
So it is expected that he would have developed. And what are the danger signs in this kind of bladder behavior? So is it a high risk?
The level of the injury is above T9. I would like to be careful about autonomic dysreflexia, sir. I will not allow the bladder to.
T9 actually will be very low. It is generally above T6 level, T6 spinal level. So if he's had an injury in the vertebra of T6, he would be having around T8 to T9 injury level of injury. So spinal hyperreflexia, autonomic hyperreflexia or dysreflexia will be less common in this situation. So, but anyway, because of combination of DESD and overactivity, there is a good chance that he may develop upper tract damage. So it is a high risk bladder. So if it's high risk bladder dysfunction, you would like to confirm what is going on. You would like to treat it promptly. How do you want to confirm it?
Sir, first of all, I'd like to know the kidney function test of the patient.
Okay, so his tests were done. Urine culture was showing E. coli. Urine was dirty on physical examination. It was a multi-drug resistant with ESBL E. coli. Hemoglobin was normal, 13.2. TLC was 7900. Creatinine was 0.6. Random blood sugar was 128. Ultrasound showed no hydronephrosis. Bladder was thick-walled with a volume of around 240 ml with debris. And he was unable to void, so PVR was irrelevant in this situation. So how do you proceed now?
Sir, at present, I would like to subject this patient for urodynamic examination. But before subjecting this patient for urodynamic examination, I would like to give the antibiotics cover because the debris is there. Since he is on CISC, so it is expected that debris will be there and E. coli is there. So I will do the UDS under proper antibiotic cover. And second thing, on examination, the
would you like to? So rectum was loaded.
So I would like to give the pre-op enema, pre-procedure enema, sir.
So basically, you would like this patient to start on antibiotics based on the culture report. You start his bowel movement also now by oral or enema agents, and then you call this patient again in a couple of or 3 days time to see whether the bowel is clearing or not. So now let's hope that the bowel is clearing, and then we do a urodynamics. Okay. So what do you expect? What urodynamic questions do you have which will make a difference in your management? So one, you said it was overactivity. Another, you said DESD. Anything else you would like to look look for?
Compliance of the bladder.
Yes, so you look for compliance of the bladder. So in this situation, you will call this patient. So let's say, I'll just come to the graph of urodynamics which was done. So can you brief me how to do a urodynamic study, how to set up? Do you have urodynamic setup at your place of work?
Yes, sir. We
Have
used
you
to.
done it yourself?
Yes, sir. We used to put two tubes, two IFTs. One is 6 French IFT and one is 8 French IFT per urethra into the bladder to gauge the free vessel. And another is a rectal balloon catheter which I used to place in the rectum.
Okay.
And before that,
What size? What size rectal balloon catheter?
Perhaps balloon catheter, sir. We used to this one glove. We used to make a glove with the catheter and place inside the rectum, sir.
No. Glove on what? On feeding tube? On what catheter?
On 12 French feeding tube, sir.
On 12 French feeding tube. So on 12 French feeding, you will put a glove, fix it there. Do you make a cut in the balloon or not make a cut in the balloon?
We make a small nick in the balloon.
You make a small nick in the balloon. Okay. So you have placed a 6 French and 8 French Foley's catheter, the feeding tubes and a rectal. And what else?
And all the pressure lines should be well calibrated, sir. And it should be devoid of any air bubble.
Okay. So you flush the channels so that there is no air bubble in the channel.
Yes, sir. And then we will fill the bladder. In this case, I will fill the bladder at a very slow pace because
No. Just first of all, you have to tell me what is the level of your transducers.
Sir, the level of the transducers is usually at the level of the pubic symphysis, and I will gauge all the pressure up to 0, and I will check the integrity of the cough impulse test.
Yes, and then you start the filling.
And then I will start.
We have to run quickly little. We have 6 minutes left. Yeah.
Oh, okay, sir. Okay, so I know that you understand. All of you should just go into the details of how to do urodynamic study. You said it right. So we'll just proceed to the urodynamic findings. So what does can the other colleague tell you? Tell something about the urodynamics. What do you find in this graph?
When there is a detrusor contraction, there is a similar contraction in the external sphincter, sir, which is measured by EMG. And there is.
Sir, during the filling phase, the bladder seems to be poor, sir.
Okay.
And when the command to void there, the EMG is still showing the activity. It means that he is having some sort of detrusor sphincter dysenergia.
So okay, good. So basically, in this you are seeing a poor compliance because the detrusor pressure is rising right from the beginning of his inflow. You see the irregular outline of the pre-detrusor, which indicates presence of phasic detrusor overactivity, which the amplitude of which keeps increasing as the filling is increased. And towards the end, when the voiding command is given, the patient doesn't have much sensation. But with the continued filling, he had high amplitude overactivity, which is associated with increased EMG activity. So this patient has poor sensations, poor compliance, detrusor overactivity, and DESD. So now, what do you want to? How do you want to manage this patient?
Sir, I'd like to keep the patient since
Hello.
Based on the UDS finding, I would like to subject this patient with a full dose course of anticholinergics.
Okay.
And I will ask the patient to do the regular CIC. So
yes.
That the volume of each CIC should not exceed 200 ml.
200 ml he was already doing actually. So sir, generally, what is the target of bladder capacity?
Sir, but given this UDS at 200 ml, there was a terminal detrusor overactivity that might fire the upper tract. So in order to safeguard the upper tract, I would like to...
Okay, your concern is right, but I would like to just say here, because this patient hasn't had any medication so far and hasn't developed any upper tract. So urinary incontinence for him has been the saver. So you would like to start him on a high dose of bladder sedative, typically a combination of one M3 blocker plus beta 3 agonist, and slowly increase the CIC duration. So maybe you can start him with a 3 to 4 hourly duration, and once and keep increasing to every 4 to 6 hourly till he reaches the capacity of 300 to 500 ml, and with no incontinence in between, right? And at the same time, you would like to improve the constipation also, right? Constipation, he may need enema, he may need a prokinetic along with the osmotic agent. A proper technique of CIC must be taught, and most important, motivation, because these people and the families are demotivated. Your motivation should be very important. How to follow up this patient? How frequently to follow up?
Sir, I would like to follow this patient initially after 1 month after putting the CIC, so that whether he's compliant with the CIC or not, or whether he is still leaking in between the 2 episodes of CISC or not.
Yes.
And then I'd like to also see whether he has developed any sort of new symptoms like the flank pain or not, or any UTI, febrile UTI or not.
Yes. So very good. So basically, the follow-up is based on risk stratification. So as you rightly pointed out, that this patient is a high-risk neurogenic bladder. So initially, the follow-up will be very early, 3 to 4 weeks. Then progressively, you will keep on increasing the follow-up duration. And if this patient, once he becomes the continent, the volume has increased, there are no UTIs, you can space the follow-up accordingly. Now, what if he doesn't respond to oral, like for capacity, for incontinence, or for constipation? What would you like to do?
We can go ahead more advanced procedure, like we can go with a trial of Botox injection, sir.
Okay. What dose do you of Botox is injected?
200 units. In the
100
rectum,
to
sir.
generally in a non-neurogenic patient, 100 units, and in neurogenic up to 200 units can be injected. For how long the effect is expected to last?
3 months. 3 to 6 months.
So in general, 3 to 6 months. Very good. Actually, I wasn't expecting this much, and so you guys are really geared up for the neurogenic examination, and particularly you, and the treatment of neurogenic bladder. And I think your patient will be safe in your. So I'll just go through. Dr. Arun, can I just take 3-4 more minutes, or is it okay?
Yeah, I think if you can wind in 2 minutes instead of this
sure.
discussion, you can make it a teaching now.
Yeah. So basically,
from your end, you can just
you can understand that. So as a urology resident, you know that the bladder and the lower urinary tract has autonomic and somatic supply. The autonomic is sympathetic from T10 to L2, and from parasympathetic S2 to 3-4, and also somatic to external sphincter. So you all know the storage phase and voiding phase. You all know the micturition reflex. I just like to emphasize on one thing. So once there are something called as secondary reflexes. Secondary reflexes are called urethra to bladder reflexes and bladder to urethra reflexes. So during filling, what happens that once the bladder is relaxed and the sphincters are tight, so once the bladder keeps on relaxing, it leads to a stimulatory secondary reflex to urethra. It is called bladder to urethra reflex. It is a stimulatory reflex in filling phase. And once this urethra is tight, means the external sphincter is squeezing. It sends further inhibitory signals to the bladder. So it is a inhibitory urethra to bladder reflexes. So now once the voiding phase is initiated, this primary, apart from the primary reflex, which is coordinated in pontine micturition center, it is converted to not only the primary reflexes are converted, even the secondary reflexes, that is bladder to urethra reflex, becomes inhibitory. Means the more contraction of detrusor, the more relaxation of the sphincter, and the more relaxation of the sphincter, the more contraction of the bladder. So this you must remember, because this is important for patients with dysfunctional voiding, not in neurogenic bladder as much, but in dysfunctional voiding. Once you understand these secondary reflexes, it will be very useful to manage these patients. So one should be aware of neurogenic bladder patterns. So one is suprapontine, in which you don't have you have typically detrusor overactivity, but you don't have a detrusor sphincter dyssynergia because the pontine innervation is maintained. Then you have above T6, in which you have detrusor overactivity along with internal sphincter dyssynergia with the external sphincter dyssynergia. So this is a very dangerous condition, which is also associated with autonomic dysreflexia. So maybe we can discuss this sometime later. Then you have S6, T6 to S2, which typically on the vertebral level up to thoracolumbar junction, maybe T12, where you have DESD along with detrusor overactivity. And then you have sacral damage. So sacral nerve damage or cauda equina or anything below T12 vertebral level will lead to detrusor underactivity, no overactivity with decreased tone of the outlet. And this is a very bad situation where the coordinated function of bladder is lost. And then you have a peripheral nerve loss, like you see in radical hysterectomies and APRs when the sacral nerves may be damaged, and S234 type of dual motor neuron problems are found. Priorities of management, you guys know that upper tract followed by bladder storage, followed by possibility of voiding, along with infection-free status, manage the lower GI, motivation of self-caregiver and the family, and a very periodic follow-up is important because it's a lifelong problem and it should be managed. But every follow-up and treatment to be tailored according to the individual case. So thank you very much. And thank you very much.
Thank you, Mank. Thank you very much. Thank you, Shashank and team. And now we move on to the case 5, and I invite Saket, Nayan, and Rahul to keep their audio and video on. And for this case, we have faculty examiner Dr. Venkatesh Krishnamurthy. I invite you, sir, to take over. Please go ahead, sir.
Dr. Arun, can you hear me?
Yes, sir. Slide is seen and you are audible, sir. Please go ahead.
Thank you so much. This has been a very interesting session. We will move on with the presentation. Basically, the entire discussion will be about understanding antenatal hydronephrosis, postnatal recognition and management, the principles. We will not go into surgical interventions and so on. The first slide, this child presented to us at age 4 months. Antenatal 28-week scan showed left renal pelviectasia, about 11 millimeters anteroposterior diameter, no ureteric dilatation, right renal pelvis seemed all right. I don't know who is going to take this question. So what else would you have wanted in this?
Sir, I would like to know about the complete ultrasound finding, including the renal parenchymal appearance, the thickness of the renal parenchyma, the dilatation of the calyces, also the bladder status and the urethral status. Also, we can check for any pararenal urinoma antenatally if it's a severe obstruction there.
Very unlikely, because this is, you will need all this in case it is very severe. So there is no mention on parenchyma and calyceal dilatation. They have already said that there is no ureteric dilatation. So your point that you want to know about the bladder, the urethra and all does not apply. All these will come in place only if there is ureteric dilatation. you cannot have changes in the bladder and the posterior urethra without ureteric dilatation. So in this instance, you will want to know more about what you have said. That is parenchymal status echoes, thickness, as well as the calyceal dilatation. So if the gynecologist obstetrician refers the parents to you with this finding and say, go meet Dr. Nayan, he is a very famous urologist, what will your advice be to the parents?
Sir, according to this scan, which was done on the 28th weeks, according to the UTD classification, it will come under the high risk. And so I will counsel the parents, regarding the need of repeat scan after a month, and then again one more scan to be done in the third trimester. So usually we'll repeat the scan once in a month. And the same time, we have to strictly counsel and sensitize about the strict postnatal follow-up and the risk of UTI. So I will advise to repeat scan after a month.
So when you say this is high risk, what do you mean high risk? High risk for what?
High risk for, sir, actually obstruction. We are more worried about the obstruction, like PUJ obstruction here in this particular case, because there is no ureteric dilatation and there is the hydronephrosis is under the high risk, as it's 11 mm APD.
Okay, we'll come back to that point later. So what else? Now you said that you will tell them to come back in a month with a repeat ultrasound. So they've come back in about 8 weeks. That is 2 months later. These are the findings.
Yes, sir. So here, sir, compared to previous scan, the APD on the left side is increased from 11 to 16. And the right side is almost same, 5 to 5.3, and the liquid is adequate. So here it's again, as APD is increasing at the 36 weeks, my plan will be, again I will counsel, and my plan will be immediate postnatal. After 2 days, I will repeat the scan, and then I will plan accordingly.
Okay. So given this finding, do you think this mention of Leica adequate, is it necessary?
Yes, sir, because prenatally in the some patients, there may be a transient oligohydramnios that is possible. So if we are suspecting, if we are finding that oligohydramnios, obviously we have to little careful about the obstruction and then counseling and all this. So postnatal management will be the most important and as soon as possible.
Perhaps you missed my point. So now this is a unilateral obstruction. There is no ureteric dilatation, which means the lower urinary tract is also presumed to be normal. In a unilateral obstruction, with the opposite side being normal, meaning the right kidney is not missing, indication of Leica being adequate, does it add anything to your own clinical diagnosis?
So this means opposite kidney is normally working, right kidney has normal function, and the urine production output is normal from right kidney, and so the Leica amount is therefore normal.
Yeah, you would expect the Leica to be normal unless there is some other problem contributing to oligohydramnios. Do you know, Saket? So what is this AFI? Do you know what this AFI is?
Sir, amniotic fluid index, sir, I don't know much in details about it.
Sir, usually we'll check 4 pockets, each pocket having the score of 4.
What does AFI mean? What does AFI expand to? What's the expansion of AFI?
Amniotic fluid index, sir, normal from 8 to 18, sir. And 4 pockets usually will check. Each pocket 4, less than 5 is the oligohydramnios.
Correct. So they look at the free amount of fluids in 4 pockets, add it up, and then that is what you are supposed to get. As you said, anywhere from 8 to 18 with variations depending upon which trimester. It decreases, especially towards term, but anything less than 5 is considered oligohydramnios. And remember, we generally would expect something like this only if it is bilateral hydronephrosis. Bilateral dilatation, then you are looking at compromised renal function. In a unilateral obstruction with the ureters being normal, this really doesn't add too much, unless from the obstetric point of view, there are so many other implications that they will need to do this. Okay. So 38 weeks, they had advised one more, and this is the finding.
Sir, it's on the left side, the APD is increasing, and even on the right side, it's increased from 5 to 8. So this is definitely under the high risk. No obvious ureteric dilatation. My next advice would be the immediate postnatal follow-up, and we'll repeat the scan after 2 days. And if there is a persist hydronephrosis, then I would like to do the further evaluation and management.
Saket, any difference of opinion?
So now in this case, I would like to know the AFI, sir, because right kidney APD is also increasing.
Yeah. So I have not put up the rest because we've covered it, but there is no great calyceal dilatation. Parenchymal thickness is normal on the right side. So again, the AFI is not too much of an importance in this patient for all practical purposes. Okay, so let me ask this question. At 38 weeks, APD of 8 millimeters, Saket, is this important? Is this not important?
So this is normal, I suppose, 6 to 8.
Yeah, so you really wouldn't expect compromised renal function for this. So now you said, when would you want to repeat this scan? Now, post-delivery, postnatal.
After 2 days.
Why after 2 days?
So
do you have a range? Can you do it after 2 weeks? Can you do it after 1 week? What?
Sir, after 2 days, before 1 month, we have to do, sir.
Yeah. Okay. So what is the logic behind that?
So initially, after initial 2 period, baby can be dehydrated, so there won't be much urine production. So we have to stabilize the baby for at least 2 days. Then we can do a repeat scan after 2 days to check for the hydronephrosis.
Yeah. So, okay. So let me put it, the very fact that you have a range from 2 days to 1 month implies that there is no emergency to go and do the scan. Now, let us say at 2 days you find that the dilatation is the same. Would you consider intervention?
No, sir.
No, sir.
Exactly. So what you are doing is to see, are things getting worse? Again, it is risk stratification and to counsel the parents. Your emergency scan after 2 days would be of importance only if it is bilateral obstruction. Then you will look at compromised renal function. Then you will not just do a scan, but you will also look at the serum creatinine electrolytes and so on. But generally in such a case, if it is bilateral, as we've already covered, you will look at the ureters, the bladder, the posterior urethra, liquor, how much of oligohydramnios. So these are all things that come into play when you have bilateral. In a unilateral obstruction, yes, you have a good window period in which you can go and do this. As I've said, it helps in counseling the parents, and don't scare them. Counseling is always in the form of reassurance that even if the child needs a surgical intervention, things will turn out well because this is a simple obstruction. Okay, so this is birth history, full term, LSCS, birth weight is good, 3 kgs, 4 days postnatal.
Sir, based on this ultrasound, there is a resolution of hydro on the right, and on the left side, APD is still 14 mm after 4 days. So, according to the classification, it will come under the intermediate risk. And my advice after the scan would be the repeat scan after 3 months. And if 3 months scan also showing the same hydro, then I may need the renal scan and then intervention.
Rahul, Saket, any opinion?
So on that side, the APD has been decreased from 24 to 14. So, sir, I'll keep the patient on observation and follow up USG after 3 months.
So let me go back to the point that we discussed. So you have a window of 2 days to 1 month specifically for this reason. I'm going to show you a slide later. Specifically for this reason that changes happen. There is a certain amount of physiological hydronephrosis that happens in the antenatal period. You don't know which is physiological and which is not. Have you followed me so far? So you have to know which is physiological and which is not. Things keep changing. Therefore, the APD of 7 to 10, greater to 10 in the second trimester, third trimester makes sense because you know that changes may happen. 1. 2, you will do it early or you will not put it off, because if it is going to be significant hydronephrosis, you would like to know early. 3, is there a cutoff? Let us say, if they say it is only 2 millimeters or 4 millimeters in the third trimester, would you say, look, there is no need to worry at all, go ahead? Have you followed? It is more in the second trimester. Let's say it was 8 millimeters. Then in the third trimester, it is 4 millimeters. Would you tell the parents that, look, there is no problem, don't worry at all? Do you have a cutoff beyond which you will say, don't worry?
Less than 4 mm.
So let me answer that. There is no cutoff. There is no cutoff. So if you have noticed antenatal hydronephrosis of any degree, that is a dilated pelvis, then all of them qualify for a postnatal ultrasound simply because there is no cutoff. The percentage of these going into a full-fledged hydronephrosis is less, but the point is, does it happen? Yes, it does happen. So be very clear. You know the range for the second trimester, you know the range for the third trimester. You will not look just at APD, but you will look at the parenchymal echoes, the parenchymal thickness, the calyceal diameters, and then later ureter. If the ureter is dilated, then you will look at the bladder and the posterior urethra. So remember this, that just because this has decreased means nothing. And if this was, of course, postnatally, if it is there, you will still follow up 3 months later. Yeah, we'll have to finish this because we've already spent about close to 14 minutes on this.
Here, sir, APD is increasing on the left side. It's now from 14 to 24. And as age is 3 months, now I would directly straightforward, I will advise for EC renogram to look for PUJ obstruction here.
Yeah. So there are two things. In the previous slide, both the parenchymal thickness were equal. Now it is 8 millimeters here and 2.7, which means there is increasing parenchymal thinning. Two, the lower calyx is also dilated. Earlier, this was not the case, and the APD has increased. Why do you want an EC renogram? Why do you want an isotope renogram?
To rule out PUJ obstruction.
Is there any doubt of a PUJ obstruction in this?
To know the relative function of both the kidneys, GF.
Rahul?
Sir, here our aim is to first anyway document the differential renal function in GFR, because based on that we can plan the definitive management. And the second would be the follow-up. When we follow up the child, we need the baseline function in GFR so that later post-pyeloplasty we can follow.
So your ECG renogram, see the days when you wanted the renogram to say is there obstruction is gone, ultrasonologically now the diagnosis is highly accurate. To the combination of progressive parenchymal thinning, low calyceal dilatation, increasing APD, all of it points to, and the absence of ureteric dilatation is very clear that there is an obstruction there. So you will do an EC renogram to, now suppose EC renogram shows good function, fairly equal. What would you do?
Sir, we have to look for drainage pattern, sir. If drainage, it's obstructive drain.
Regardless. Now, as I've said, there is no doubt that all this is happening. There's an obstruction. You do a renogram and you find that the GFR is good. I will say about 40 ml per minute.
So we will like to intervene at this stage, sir, to preserve the kidney because it's already hydronephrosis is extending to calyces. So we can plan for.
So I understand that. I'm asking for the role of the renogram. Okay, we won't dwell too much into this. This whole thing is about antenatal hydronephrosis. So you know that if you look at this, so there is fairly good function on both sides. So here, this is it, 17 ml on the left, 53. So I don't see any reason to not intervene in this patient. But remember, so the EC renogram serves a different purpose. One is to establish a baseline and look at prognostication. That's very important when you intervene surgically. You have to prognosticate. If at 17 ml without any infection is a very different outcome from 17 ml with infected hydronephrosis or pyonephrosis. Remember that. Clear? And two, suppose you find that these are fairly equal, then you will look at progressively, there is no need to rush in. You will say, let me wait and see if there is decreased function because there are papers in which you find that this is actually recovered over time. The third is if it is gross hydronephrosis, there is also an element of renal dysplasia which may not contribute to good recovery in function. And fourth, you must know of hyperfunction, increased GFR in cases of hydronephrosis. Anyway, I'm not going to do that. So this is, we won't go into that. So dilated external pelvis, thin parenchyma, pyeloplastida. Okay, here is the second.
It's a 2-month child at the 36-week ultrasound detail is given in APD of 8 mm. Obviously, like previous case, we need complete ultrasound findings, including all the renal morphology and the ureter and bladder status.
No, all negative, all normal, which is why I've left that out. So
If this is only the finding 8 mm APD, then at the 36th week, it will come under the low risk, sir. We have to follow post. Now it's already 36 weeks, so postnatal will advise one ultrasound. between 2 days to 1 month. AFI, they mentioned normal.
Yeah, postnatal day 1, very anxious parents, very anxious obstetrician. So here you are.
So it is still a low risk. So we can repeat after 6 months.
So when you say this low risk, Nayan says moderate risk, what classification are you following that says
UDT.
low risk? When you give me some classification for this,
Sir,
antenatal,
UDT.
where would you classify this antenatal?
Antenatally, also there is a high risk, low risk, and high risk, sir. With 3 grades. Grade A is if in first trimester if it is less than 7 mm dilatation with no other positive findings. Then grade B is 7 to in second.
Which classification is this? What is this grade B, grade A? Which classification is this? Are you following? Are you aware of a classification?
Sir, UDT classification, sir.
Okay, so we're coming to that. So typically, this is what I mentioned in the previous case. So here is a patient who has 8 millimeters, turns out to be 10 millimeters. The rest of it is all normal. At 2 months, it is 14 mm. Parenchymal thickness is 7 mm, and now you find that the lower ureter now is dilated.
Now on the left side, there is a hydroureteral nephrosis and a MCU not showing any VUR. So here my concern is regarding 2 things. There may be the primary obstructive megadural, or there may be the ureterocele or ectopic ureter.
So there may
Because earlier there was no ureteric dilatation. Now the lower ureter showing 10 mm.
So would you have done an MCU study so early at 2 months?
Sir, if at all any surgical intervention required, usually we will do
Well,
it.
see, now the diameter is not really significant. Do you think 14 mm is a very gross hydronephrosis?
No, sir, but lower ureter is 10 mm is, it's...
Yeah, of course, you know there's an abnormality. Is the parenchymal thickness decreased at 2 months? 7 mm parenchymal thickness.
No, it's a fair...
normal.
So here you have dilatation that is not very significant. You have some moderate dilatation, good parenchymal thickness. The only change has been now that you have the lower ureter. Again, I'm repeating what I said. The fact that you have a window of 2 days to 1 month is because this antenatal hydronephrosis varies. It evolves in either direction. It can resolve or it can increase, which is why you have this, unless it is very severe or bilateral. So your indications for going about this in a hurry will be solitary kidney, bilateral renal dilatation, lower urinary tract significant dilatation. These are the indications for you to be a little more emergent in the way you will approach these children. In this, there is really no need to rush in and do an MCU so early because everything seems okay. Anyway, as you know, everything else, that is, I'm talking of, there's no infection, there is no raised creatinine, all that. Okay. What triggered this was the fact that this child had UTI. Now this changes the paradigm. So if the child presents with UTI, you will no longer wait to say that all this is normal. You will proceed. So have you understood? This is what I was trying to drive home. Okay, anyway. So these are the images. You can see that there is significant dilatation, but you also see that there is good parenchymal thickness all around. So what next? You've seen that there is UTI, there is ureteric dilatation. What do you want to do?
Sir, I will counsel the parents regarding the first step would be the treat the UTI first, and then later I will confirm my diagnosis of primary obstructive megaureter.
How will you confirm?
By doing the EC renogram, sir. Or while doing the diversion, because there is a UTI, I am planning to do the diversion. So at the same time, I can do the retrograde pilogram also. And then later I can do the EC renogram on follow-up to just confirm the function.
I have a question before I wrap up. Now, the MCU shows no reflux. The MCU shows no reflux. It shows the ureteric dilatation to the lower end. What other diagnosis do you have in mind?
Sir,
that you need to confirm with a renogram.
One is, sir, first is primary obstructive megaureter. Second is the ureterocele. Third would be the ectopic ureter.
Yeah, exactly. So all that, you won't find out all that on a renogram. You ask them to repeat the ultrasound and say, look, is this an ectopic ureter? Is there a ureterocele? All those things are easily found out with a ultrasound study. Yeah. So now when a child has infection in an obstructed system, then everything changes. As I just said, so emergent treatment will happen when you are doing this. Anyway, here it is. This renogram was not done to find out where is it obstructed, primary obstructive megaureter. You want to know what is the function of that kidney, because once you intervene, you will need to know, prognosticate again. Everything is about prognostication. So underwent a cutaneous left ureterostomy early simply because we didn't want further renal damage. Okay. And remember, in a primary obstructive megaureter, you don't expect renal function to be affected as much as you would in a PUJ obstruction. Remember this. Or in a gross VUR. Suppose it's grade 5 VUR, you expect renal dysplasia, and therefore you wouldn't. So the very fact that this child had so much of decreased function with good parenchymal thickness indicates that you have to do something. Okay. So are you aware of the grading systems? Let me just finish this. So this is a seminal work that was done long back. This was about 20 years ago. They studied around 11,000 scans and at 18 to 23 weeks. Look at what happened. 4 to 7 millimeters, 80% resolved antenatally, 20% persisted at birth. Of those, 82% resolved at 1 month, 18%. And if it is more than 7 mm, you find that none resolved antenatally, 100% persisted, 44% resolved at 1 month, 30% required surgery, and then, of course, for various reasons. So this is a picture that sums up what happens to antenatal hydronephrosis. Earlier, we had the SFU grade, Society for Fetal Urology, and these were the grade 1, 2, 3, 4 at that time. We don't look at the SFU grade 1 for the last nearly 7-8 years because we have the UTD system. So the SFU system was subjective and focused only on the upper tracts. The drawback, it did not include the entire collecting system. And therefore, the upper tract dilatation grading with different parameters, I want you to remember this. It has a 6-point template. Several societies have been involved in framing this grading system. Some of it is on the base of meta-analysis. A lot of it is on expert opinion. Essentially, this is a system that has been by consensus. Remember this. So this will undergo periodic evaluation, and modification. So it's both objective as well as subjective. There's a 6-point template and is a more pragmatic approach. So don't expect a lower tract information on every case unless it's an associated problem, like a bladder diverticulum and so on. If it is only PUJ obstruction, then you don't need to do it. So here, this is what I was telling you. Antenatal, you do it as UTD A1 or UTD A2 to 3. A represents antenatal. So these are the 6 points in their template that you will need to look at, and you already have the parameters explained. So again, risk I said is of renal damage and renal recovery. That is the risk that you are talking of. UTD A1 is just low risk. UTD A2 to 3 is increased risk. And remember, the after birth, it is the same, 48 hours to 1 month, 48 hours to 1 month. So even if it is an increased risk, you don't rush in to do anything. What will change is, as I said, posterior valves, bilateral hydronephrosis. Again, you have the P1, P2, P3. So this is for Rahul. This is the classification that you will have to put in when you say, look, I will classify this as P1, P2, P3. The parameters remain the same.
Yes.
Risk-based management. Again, so remember here, functional scan is at the discretion of the clinician, but you must be very clear what you want. Don't look at a functional scan to diagnose a condition. A functional scan is just that. It is functional. Is that clear?
Yes.
Yes, sir.
So when do you worry? Remember, oligohydramnios, bilateral condition, uretrocele because this is obstructive. When you say bilateral, then it also means solitary kidney. When every part of the urinary tract is dilated. And of course, as I have shown you in that condition, when you have other conditions coming in, like maybe damage to the kidney for some other reason, presence of infection, then these change the requirements of management, and therefore you will do it in a hurry. Yeah, thank you. Thank you, Dr. Arun.
Thank you, sir. Thank you very much. Thank you, Saket, Nayan, and Rahul.
Thank you, sir.
Yeah, I think we with this we end today's session also, and I think 10 case scenarios, 3 radiology rounds, overall 13 sessions. Thanks to all the faculty with their very thorough and passionate involvement in the excellent case discussions, which have make these exams not only exams but as a learning exercise for all the residents. Dear residents, thanks to you, because no program can be successful if you are not actively involved. Your attendance on both the days have been 150, close to 150 plus, but we expect a little more on all these exams, to all these sessions or the programs meant for residents. I think those who were part of the case discussion would have become much wiser, and those who were sitting on the sidelines or watching the others answering the question would have also gained a lot. The bottom line is think, plan, speak and articulate well, common thing commons and rare things little later, and speak what you practice in your department of urology. That was the basic message from the Dr. Keshamurthy and then to Dr. Rajiv. So over to you, Keshav sir.
Thank you, Dr. Arun. Let me, on behalf of the USI and the ISU, thank all the faculty yesterday and today who have put in a lot of efforts to discuss these cases, and I hope the residents have benefited from these discussions. You need to carry along the way the discussions were held, and as Arun has told you about how the common things need to be mentioned first. You have to follow those things. I wish all the residents all the best for your exams, and all of you do well. Over to Dr. Rajiv Sood for his concluding remarks.
Thank you, Dr. Keshav. All the residents who have attended, they are going to be immensely benefited, we are sure, because this is a lot of effort and planning, and the selection of faculty has been the effort in that direction. We have conducted mock exams now, several case scenarios which are discussed now and were discussed earlier also in the earlier exam, and also in the OSCE subspecialty based. I think it will help all of you in the exams, forthcoming exams. I know that around 140 residents have appeared already in theory of National Board of Examination. More than that, in for MCH, they are appearing or they have appeared, and this all makes 300 plus residents, the attendance of 150 plus, which of course will be including some of the second year or first year students also, show that there is more effort needed from the faculty also, and also the various institutions in more and more popularizing this format. And this is the format. If there is a lockdown or there is another unforeseen circumstances, on the same format, virtual format, also the exams are being conducted. So Indian School of Urology has tried that all the case scenario, all the modes of examination, radiological table now, and earlier the instruments, and all situations are covered. The faculty has told you very clearly that how common things are to be handled first, and should be answered first, and then you go for more complication like general investigations, and then go to the special investigation, and sequencing is important. And all these things are there, and whenever you get stuck, there is a tough tip that don't just stick on one point and try to wriggle out from the situation. And we know that you have read everything, you are preparing, you are now polishing with these mock exams how to handle the examination, and wish you all the very best for future. And we will also expect that you give our your feedback what more you want. And USI ISU is always striving to do this job, and to make your curriculum uniform, effective, and with the involvement of best of faculty in the country, whom some of them you are actually going to face in your exam. So this is a very good opportunity you have taken. Wish you all very, very best. So with this, we conclude this mock exam, very effectively conducted. And congratulations to Dr. Arun Chawla also, who has done a lot of hard work, and our whole council, USI team, and scientific programs head, Dr. Keshav Murthy. Thank you very much.
Thank you, sir. Thank you to Kiran also, Navneet and Kiran, for their logistics support. Yeah.
Thank you.
Keshav, sir.
Thank you.
Thank you, sir. All the best to all the residents who are appearing for the exam. Best wishes. Thank you. Bye for now, sir. Bye, sir.
Thank you.